Okay, so tonight we're going to go over a bunch of different causes of altered mental status. So we're going to go over diabetic emergencies, seizures, strokes, syncope, a bunch of different ones. So please just make sure about an hour from now, 9 o'clock-ish, to remind me to give you a break. Just interrupt and remind me to give you a break because we got a lot of stuff to do tonight. So I want to make sure you can stay awake from it. So about 9 o'clock, just remind me to give you a break, and then we'll come back and we'll pick up and finish up. Okay, so just a quick review of some of the anatomy and physiology of, what allows us to stay conscious. Okay, so we know that the brain is the organ that, basically controls our level of consciousness. And inside the brain, there's a specific part called the reticular activating system, RAS. Not going to ask that on the exam, okay, but you do need to know that the brain, which I'm sure everybody knows by now, the brain is the organ that's responsible for consciousness amongst a lot of other things, okay? And whenever the brain is not getting what it needs, which would be oxygen, sugar, water, right? I mean, you know that when you're fasting and you start to get dehydrated, right, you get a headache. So that's again showing you that the brain is not getting what it needs to function properly. Okay, so at the very basics, right, we need oxygen, okay, we need glucose, and we need water to keep the brain functioning. I mean, we need a bunch of other things, but those are the three most important things that we need to keep the brain functioning. Okay, so when we talk about somebody having an altered mental status, a lot of times the cause will be one of these three things, right? So it could be hypoxia for lack of oxygen. It could be hypoglycemia or low sugar for a glucose problem. Okay, or it could be dehydration from the water standpoint, right? Now, obviously, you could have problems with trauma. You could have problems with people being temperatures outside of the normal environment. Okay, but there's a lot of different reasons why the brain would not function properly. Okay, and that's what we're going to talk about tonight. Okay, so again, infection, you've heard of meningitis, encephalitis, right? There's a lot of different types of infections, West Nile, right? There's even mosquito-borne types of bacteria and viruses that get into the body, right? So there's a lot of different reasons. Okay, on the exam, they don't call a stroke. So a stroke is basically similar to a heart attack, what happens in the heart, but it happens in the brain, okay, where there's not enough oxygen getting to the brain because there's an interruption in blood flow. So it could be either from a clot developing, like we had with most heart attacks, or from a rupture of a blood vessel, which is, again, just like in a heart attack, it's pretty rare to have a heart attack caused by a rupture of a blood vessel in the heart. It's also in the brain, not so common. Probably 90% of the time, it's a blockage issue, which we call a dry stroke, versus a wet stroke or hemorrhagic stroke where a blood vessel ruptures. Okay, and then again, hypoxia or something like that could be another cause of it. Okay, so obviously people have altered mental statuses. They're not thinking clearly. They probably don't mean to be dangerous, but they could be dangerous. One of the things you're going to find out or see, right? We routinely go on calls where people's blood sugars fall low, where diabetics, their blood sugar falls low. And you would think because their blood sugar is low, they would have no strength, right? They have no sugar in their body, so they would have no strength. But actually what happens is that when your blood sugar starts to drop, your body secretes a lot of different hormones trying to keep the body functioning. And one of the hormones it secretes is adrenaline or epinephrine. And we know that adrenaline or epinephrine is our emergency hormone. So when that gets into the bloodstream, those people actually have a lot of strength. So what's going to be interesting is that to be able to help them, like let's say the paramedics show up and they want to start an IV and give the patient some sugar through the IV line, they may actually need you to hold the patient down so that they could actually start the IV because this patient has such strength from the adrenaline. If it was just the fact that the sugar was low, they'd be just laying there with no strength, but they get this burst of adrenaline and they become very difficult. So now they start flailing out, swinging their arms and everything like that, and you're within reach. And, I've had situations where I've been even hit. So it's not that they're trying to hurt you. They don't know what they're doing because, again, their brain's not functioning properly because they don't have enough sugar, but they can, accidentally, as they're just, acting bizarre, flail out and hit you. Okay. Again, altered mental status from the standpoint of the police getting involved would be more like a drug or alcohol type of thing, more than a medical problem, right? I mean, usually medical problems we can kind of manage on our own, okay? Again, hypoxia always can be a problem, right? So you'll see people who are short of breath and you're trying to help them and they're totally not following your direction. They're all over the place. They're pulling things off that you're trying to put on them, oxygen, whatever, and they're just totally not cooperative. Again, when the brain is not getting the oxygen it needs, they're not going to process information correctly, and they're not going to follow commands. They're not going to do. They're so crazed from the sensation that they're suffocating that they don't act appropriately and stuff like that. So that's again one of the things that could be happening. Okay, so obviously we always treat our life-threatening problems first, okay? If the patient's pulse ox is low, okay, or they're showing any signs of needing oxygen, we would give them oxygen. Okay, again, a patient with an altered mental status may not be, what we call protecting their airway, may not have a good gag reflex, may not have what we call a patent airway, right? Those are all the different terminologies you'll see being used. So if that's the situation, we may need to maintain their airway. Now, obviously, if they're sitting up talking to us, they have a intact airway. We're talking about somebody who's unconscious and may not be able to have a good gag reflex. So if they were to vomit, they may actually aspirate that vomitus down into their lungs. So what they're saying here is that obviously have suction available, be prepared to roll the patient on their side if they start to vomit or anything like that, okay? Now, baseline mental status, if you get there and they already have an altered mental status, the only person that could provide you with their baseline mental status would be family or bystanders, right? Because by the time you get there, it's already altered. So you could always, one of the things you would always ask family is, how were they, prior to this episode, what is their normal mental status? Are they 100%, when they're good? And then you have something to compare about. So usually, it's going to be family members, bystanders, and stuff like that to get the information on the baseline, okay? Medications, okay, medications a patient taking on are always helpful. The problem is that there's so many different medications, it's almost impossible to know what every medicine is for. But again, if you have a smartphone, you could always look it up. Just realize that certain medications have multiple uses, so that what the first piece of information you get on a medication may not be the actual reason why a patient's taking it. But for the most part, looking at patients' medications can start you asking the right questions. In other words, okay, this patient's taking this medicine, it's usually for their heart. Do they have any kind of heart problems? Do they have high blood? If they're taking a medication to control their sugar, are they taking this because they're a diabetic, or maybe they're taking it because they're trying to lose weight? So, there'll be different questions that you'll learn to ask based on the different medications you see. Now, people may have information on them. A medical alert bracelet you may have seen is either a bracelet or a necklace or something that has engraved on it the patient's different medical conditions in case they're unconscious. Very common for people who have seizures to have that. Very common for people who are diabetics to have that, because they may be unconscious and it offers a way for us to get some information about them, okay? Or they may just have information tucked in their wallet. Again, I wouldn't take their wallet and start going through it. I would hand it to the police and ask them to look through and see if there's any medical related information and stuff like that. Now, from a pediatric standpoint, obviously children, depending on their age, may not be able to offer you a lot of information, okay? Nor may you be able to pinpoint their mental status, right? So we always kind of go by the fact that, if you're there and they don't know who you are, they should be watching you, right? They should have their eyes glued on you because you're somebody that they don't know, and therefore they're leery of you. So if a kid is totally not caring you're there, it could be that they have an altered mental status. Now, usually the parents or the caregivers or the bystanders are the best source of information on how the child appears to them versus how they are normally. So, it's not, most of the times there's going to be a parent or caregiver. It's very rare. You're not going to see that. Obviously, if the child's at school, it may be a little harder to get that information. But again, usually the teachers have an idea, unless it's, the very beginning of school, have an idea about, how the child normally is and stuff like that. Okay, so now the disease of diabetes, okay? So diabetes is a problem with the patient being able to control their sugar levels, but it's not controlling their sugar levels in their bloodstream. The problem is getting the sugar out of their bloodstream into their cells, right? Because we need the sugar to get into the cells, just like we need hemoglobin to carry oxygen into the cells. So in diabetes, the problem is that the production of a hormone called insulin is either not being produced, okay, or that because they're been overweight for a long period of time and have a lot of sugar, okay, their cells get resistant to their insulin and don't allow the insulin to carry it in. So we basically have two types of diabetes. We have type 1, which is what they call juvenile onset. A juvenile you know, the English word for a young person. Okay, and that's people typically who don't have the cells present in their pancreas to make insulin. Okay, and that starts, you know, at a young age. And then we have adult onset or type 2 diabetes, which typically happens in people who are been chronically overweight for years and years and years. Okay, and again, because they've been chronically overweight, obviously their body is in a high sugar environment, right? If the person's eating a lot, their body has been in a high sugar environment for years and years and years, and they get what's called insulin resistance, which means that the insulin is being produced by the pancreas like it's supposed to, but it's not actually working to carry the sugar into the cells. Okay, so let's review, you know, a little bit. How do we get sugar into our bloodstream? So we get sugar into our bloodstream by doing what? By eating food, okay? And that food then goes into our stomach. It starts to get broken down and travels into our intestine. And in our intestine, all the good things that we need out of the food is drawn out of the food. And one of the things that's drawn out of the food is sugar. So the sugar comes out of your intestine because there's capillaries that line the intestine, and it's brought into your bloodstream. Okay, but now where it really needs to get to is into your cells, because the bloodstream is just a transport mechanism. It's just a highway to transport that sugar throughout your body. So the most of the cells of the body, with the exception of the cells in your brain, need insulin to carry it into the cell. Because remember, we said cells have a cell membrane or a cell wall around it, right? So it's not just a blob, it has a shape to it. So it's got a wall around it. The only thing that can bring sugar through that wall into the cell is insulin. So insulin is kind of like the key that turns a lock on that cell wall and opens it up so that sugar could get in. Okay, so if there's not insulin, there'll be plenty of sugar in the bloodstream because you were eating food, but it won't get into the cells. So the cells now have a very low amount of sugar, which means they cannot make energy, because we said that the typical the typical energy that a cell makes is called aerobic energy, aerobic metabolism, when it burns the sugar and the oxygen. So it needs both of those present. It needs oxygen and sugar present to burn to be able to make energy. So if there's not enough sugar present, it's not going to make energy. And that's why we see people who typically have low blood sugar emergencies feeling weak and tired, having altered mental status, because all the different cells of their body can't function properly. Now, again, the brain, okay, does not necessarily need insulin to bring the sugar in. But if the sugar is low in the body because the person didn't eat, then there's actually no sugar in the bloodstream to bring it, bring up to the brain. So we're going to talk about the different types of emergencies and how they happen and how they relate to what's going on, with the patient. Okay. Okay. So glucose cannot get into the cell, okay, without insulin carrying it into the cell. So now we have two different types of very important substances that the cells need that we see have to be carried in. We have oxygen having to be carried in by hemoglobin, and we have insulin having to be carried in by, sugar having to be carried in by insulin, okay? Now, again, the brain cells don't need insulin to carry it in, okay? So, but we'll talk about the different emergencies and why patients have, altered mental statuses, so on and so on, okay? So the pancreas is the organ that produces insulin, amongst some other things that it does, right? Yesterday, we said that pancreas produces a lot of digestive enzymes that help break down food, okay? The insulin travels from the pancreas, okay, into the bloodstream. And if you ate food and there's sugar in the bloodstream, it will then travel around and go to whatever cells of the body it needs, and the insulin will carry it from the bloodstream into the cells. Remember, the sugar got into the bloodstream because you ate food, and the sugar was absorbed by the capillaries that line your intestine and brought into your bloodstream that way. So you actually have two areas, where you could, quote, measure sugar. When we measure somebody's sugar by sticking their finger, we're measuring blood sugar level, okay? There's no real way of measuring sugar inside the cells other than going by mental status, right? So somebody could have an adequate sugar in their cells, but if they don't have enough insulin, it's not getting into the cells of the body. So we'll see the two different emergencies, and how they each cause a problem inside the body. Okay, so again, insulin is produced by the pancreas. Okay, it goes to the different sites on the cell that sugar needs to get onto. It opens them up so that the sugar can actually pass through the wall, of the cell into the cell and give it the sugar it needs to burn along with the oxygen. Okay. Now we said there's two types of diabetes, and then there's two types of diabetic emergencies. So the two types of diabetes, type 1 diabetic, again, typically starts at a very young age. It's called juvenile onset diabetes, which means, again, starting when somebody's very young. The cells of the pancreas, okay, that make insulin do not work properly and they're not making insulin, okay? So the only thing that person can do is take artificial insulin. They are trying some different things where they're infusing cells, that are actually the beta cells of the pancreas that make insulin from other people into the pancreases of diabetics and see if somehow they could trick the diabetics pancreas to work and stuff like that, but usually it's rejected. So they're trying all different types of things to do it. But right now, what basically happens is those patients have to take insulin. Now, up until a couple of years ago, that involved taking a series of shots a couple times a day. And now they have what they call an insulin pump, okay, which is a small pump that somebody wears, okay, on their body by their stomach, okay, and it actually does two things. It has inside of it insulin. It could actually, a lot of them have two hormones. They have insulin and they have a different hormone called glucagon. Okay, so insulin raises blood sugar levels, glucagon lowers, insulin would raise the blood sugar levels in the cell, but lower it in the bloodstream, and glucagon would raise the blood sugar levels in the bloodstream by breaking down a storage form of sugar that we all have in our body called glycogen, and I'll explain that a little more, as we go on. But what the insulin pumps do is that they actually monitor the patient's own sugar levels. And as the patient needs more insulin, in other words, as the patient's blood sugar level rises, it actually secretes insulin into the bloodstream to allow some of that sugar to cross over into the cells so the cells can use it. And they actually refer to it as an artificial pancreas because it's kind of doing the role of what the pancreas does. And all the person needs to do periodically is put a new cartridge of insulin into the pump. And, obviously there has to be a way for the insulin to get from the pump into the patient's body. So that's a small tube that comes off the pump, okay, and goes to what looks like a little round Band-Aid on the patient's belly, but there's actually a small little needle under the skin, and it pumps the insulin that way into the body. So, I would assume periodically, if it's every couple of days, they're also changing out the needle part of it, okay? But again, you're talking changing needle maybe 2 or 3 times a week, okay, versus giving yourself, multiple shots a day. So it's, the compliance with it, the patient actually taking care of themselves is much better with it, okay? Remember, prior to the discovery that insulin from animals could be used in people, they actually, years ago, used to use the insulin of pigs. There was a very close match to the insulin of humans, and that's what they used to inject in people. Now the insulin that's injected in people is what they call recombinant, which means that it's actually made in a laboratory chemically. It's not actually from an animal. But up until that concept of injecting somebody with the insulin of a pig, every diabetic who had type 1 diabetes died within a short period of time. Soon, as soon as their cells stopped making insulin, they only had a matter of days, if not weeks, before they would die. So, people in the very, if you go back hundreds and thousands of years ago, people didn't even know what, diabetes was. They didn't know what the problem was. They just knew that the patient basically became unconscious and eventually died. So they didn't know the actual cause of what it was. So, the disease of diabetes is very debilitating, but with proper management, okay, the diabetic nowadays could live to, a ripe old age. If you go back to say the 20s and 30s, even maybe the 40s, the average lifespan of a diabetic was probably in their teens to 20s, and it's slowly increased to the point where diabetics can live a somewhat fairly normal life. They have to watch things, they have to watch to eat, they have to watch their diet, they have to watch for injuries and trauma and stuff like that. But I'll talk about what happens that with diabetics, their wounds don't heal as quickly as wounds of non-diabetics and stuff. But they pretty much can live a full life, a healthy life and stuff like that. But again, they have to take some responsibility for their problems and take care of themselves, watch what they eat, make sure they follow up with their endocrinologist, make sure they take their medicines and everything like that. Okay, so type 1, again, juvenile onset, the cells in the pancreas do not make the insulin. Type 2 diabetics typically is what we call adult onset diabetes. Typically happens in people when they're, in their adult ages, probably 40s and 50s and stuff like that. Can happen younger. As a society in the United States, obesity is a big problem. We even have kids in, school age kids getting overweight because of the sugary foods and stuff like that, sugary drinks, sugary foods, lack of exercise and stuff like that. But really, type 1 diabetes is more genetic. Type 2 diabetes is usually brought on by lifestyle. Okay, now you can argue a little bit that they're probably a little predisposed to it, and stuff like that. In other words, they probably have some genetic issue. But really, if you were living healthy, okay, and not overweight, you probably would not develop type 2 diabetes. So what happens is these people are chronically overweight, okay, which means that in their bloodstream, the levels of sugar are chronically high, okay? And they develop this term called insulin resistance, which basically means they do produce insulin, but their cells become resistant to it, do not accept it as being able to carry the sugar from the bloodstream into the cells, okay? So initially, what happens with these people is they try to control it with diet and exercise and oral medications that allow the insulin to work better, okay? In fact, somebody who's grossly overweight and is pre-diabetic or is even become a type 2 diabetic, if they have any types of the different gastric bypass surgeries or banding or anything like that, and they drop 20, 30 pounds, they usually within a week of the procedure actually become a non-diabetic. That's how effective it is. Now, I'm not saying that everybody who's overweight should go and get any of these procedures, because there's a lot of risk factors associated with having all those different types of procedures. It'd be much better if you could control your blood sugar by exercising and dieting and stuff like that. But if you truly can't, having any of the bariatric surgeries or procedures performed on you because you've become a diabetic because of your weight problem will actually most of the times, bring you back to not being a diabetic. Okay, but again, it's not a perfect world because there's side effects of the actual procedure that people get, and the pancreatitis, they have problems swallowing. So there's a lot of different things that can happen. So years ago, we used to differentiate very simply a type 1 from a type 2, and that a type 1 always took injections of insulin, and a type 2 usually didn't have to take injections of insulin. They usually just took medications to allow their own insulin to work. Nowadays, that's not so reliable anymore because you will have type 1 diabetics to take both pills and insulin injections, and the same thing, you'll have type 2 diabetics that take both. Okay, so that's not a reliable way to do it. Okay, so early on in type 2 diabetes, they probably can manage it with diet and exercise and oral medications, but if they're not getting it under control, they may need to actually take some insulin. And then even some of the medications used in the treatment of diabetes that's not insulin is now actually injectable. And some of it is actually in an auto injector form so that patients don't have to actually draw up the medication and inject themselves. They have, what looks like an auto injector type of device to help them take their medications. Okay, so let's go back, just make sure we understand the types of diabetes, right? So in other words, when you say somebody's a diabetic, they're either going to be a type 1 diabetic or a type 2 diabetic. And either one of these two types of diabetics can have emergencies. That's why we would get called. But the first thing is to understand type 1 from type 2. So in type 1, the cells of the pancreas that produce insulin do not produce the insulin, okay? So their problem is that they don't have any insulin, therefore they can't get the sugar from the bloodstream into the cells. So they have to take insulin. How they take the insulin really depends on their comfort level. Like some people are fine with giving themselves shots and they've been doing it for years and they want to continue doing it. It depends on their insurance coverage. But most of the diabetics nowadays, especially younger diabetics, will get what's called an insulin pump. If they're on Medicaid, they're going to get an insulin pump because Medicaid always pays, for the best of everything. Insulin pumps are probably the best way for a type 1 diabetic to manage their condition because, again, the pump itself is monitoring their blood sugar level and giving them insulin when they need it. Some of the older insulin pumps required the patient to still check their blood sugar, but most of the new ones, actually check the sugar for the patient and will give the patient, either a message that they need insulin, but if they see the sugar rising too high, will actually secrete the insulin itself for the patient. Type 2 diabetics typically happen later in life. Those patients usually are overweight, okay? And it's caused by the fact that the cells, the patient's own cells, become resistant to their own insulin. They do make insulin in type 2 diabetes because of the fact that those cells were always exposed to high sugar levels because that patient was chronically overweight for years and years and years. Okay, so that's the two types of diabetes. Now, in saying that, 90% of the time we go on a diabetic call for an emergency, an unconscious patient with an altered mental status, it's going to be a type 1 diabetic. Okay, those are the patients that tend to run into more issues than the type 2 diabetes, but a type 2 diabetic can have problems. It's just statistically, it's more common to be in the type 1 than the type 2. Okay, so now we have two emergencies. Okay, again, more likely to occur in the type 1 than the type 2. The first one is hypo, which means low, glycemia, which means sugar. Okay, so hypoglycemia means low blood sugar. Okay, and it's that the patient's level of sugar in their bloodstream is too low to get enough sugar into their cells. So they're actually probably have enough insulin or maybe too much insulin. So their problem is not insulin, their problem is sugar. So usually it's caused by somebody not eating or exercising too much and burning up their sugar, or maybe forgetting that they took their insulin and taking a second dose of insulin. Because what's going to happen, in other words, let's say you just ate a meal, you check your blood sugar, you see it's high. So you say, okay, let me take a little insulin now and get some of that sugar into the cells. So you inject yourself with some insulin, and 50% of the sugar now travels into the cells. So everything's wonderful. And I don't know, 20, 30 minutes goes by and you say, did I take my insulin? Did I not take my insulin? I'm not sure. Maybe I should take some more. So you take another dose of insulin, okay? And now you transfer the rest of that sugar from your bloodstream into your cells, but you're not eating anymore. So you basically used up all the insulin, okay, that's in your bloodstream. And once the cells burn up that insulin, burn up that sugar, they're gonna go into a hypoglycemic state and they're not going to function. Okay, so that's one way. They take too much insulin. The other way is they've not eaten enough. That's very common when people are not feeling well. Okay, they forget to eat, but they remember to take their insulin, but they forget to eat. So picture what could happen. You remember to take your insulin, but you forget to eat. So now whatever sugar was left in your bloodstream is going to go into your cells because you take your insulin, but you're not eating to replace it. So you're going to rapidly become unconscious. The overexercising, overexerting typically happens in younger people, children, teenagers, 20s, people that are diabetics but still trying to stay healthy. Can happen at day camp, summer camp and stuff like that, where kids that are diabetics, overexercise. Not so common. They usually realize what their problems are. I've had it maybe once or twice. When you eventually wake the child up, the story usually is, it was a great game of baseball. They didn't want to stop. They were doing really well. They didn't want to stop to eat, and they were running around figuring they had another minute or two before their sugar was going to get too low, and they didn't. Also, a diabetic patient who has any problems with their stomach where they have vomiting and diarrhea, that would not leave enough time for the sugar in the food to be absorbed into the bloodstream, right? If they're eating and they're vomiting, then there's not enough time for that food to stay in their GI tract, in their gastrointestinal tract, in their intestine for the sugar to actually be absorbed, okay? And the very rare problem was when a diabetic gets sick and they get a fever. So when you get a fever, you go into what they call a high metabolic rate, which means that basically everything's running quicker, right? So the famous term you may have heard is feed a fever, starve a cold, right? So when you're having a fever, your fever is your body increasing the temperature to make the environment that the bacteria is growing in inhospitable, right? In other words, it's trying to kill the bacteria by making it too hot inside your body for the bacteria to divide and grow. So when you have a fever, to be able to, generate heat, your body needs to have food, right? It needs to burn stuff to make that food. So that's why I always say feed a fever, starve a cold, because a cold typically is a virus, okay? And you don't have a fever a lot of times with viral infections, or at least a fever is not what's actually going to get rid of the viral infection, okay? But again, it doesn't hurt to, eat when you have a fever. It's always better to eat. But what they're basically saying here is that when somebody has a fever, okay, they're going to burn up more sugar than they would if they didn't have a fever. And shivering is what? Shivering is a way of keeping warm by your body actually very quickly rubbing muscles together. You don't see it because it's inside your body. But when you shiver, it's actually muscles rubbing very, very quickly together. And if you rub your hands very quickly together, you get friction and you get heat. The same thing happens when you rub muscles together, you get heat. Most of our way we increase our temperature is by our cells burning more food. Remember, our cells are just like little power plants. So they're actually, when they make energy, they're actually burning sugar and oxygen and making energy. So that burning of the sugar and the oxygen together, okay, actually generates heat. So the vast majority of our heat is caused by just your normal metabolism, right? Remember, metabolism is the word for, making energy by burning sugar and oxygen. But if you needed to make additional heat because you're very cold, then shivering would be the second way that you make heat. Okay. So again, hypoglycemia, the low blood sugar emergency. The problem here, okay, is not that they don't have insulin, right? The problem here is they don't have sugar. Now you have to figure out, why do they not have sugar? Is it they took too much insulin and got rid of their sugar? Is it that they didn't eat? Is it they burned it up by exercising? Did they not absorb the sugar because they were vomiting it out? And again, this is pretty rare, but when we talk about sepsis, which is a body-wide infection, sometimes you can see that people who are septic will either have a very high sugar or very low sugar. Okay, so how do we tell the difference between a low blood sugar emergency and a high blood sugar emergency? So one of the clearest things is that their mental status is going to decrease is going to go downward, get worse very quickly, because as soon as they don't have enough sugar going to their brain, they're going to have an altered mental status and very quickly get confused, tired, to becoming unconscious. So it's a very, very rapid onset in minutes, where the high blood sugar emergency typically takes days to even a week to develop, okay? Again, since it's so quick, they're gonna have an altered mental status, again, almost making it look like they're drunk or intoxicated or something like that. That's why yesterday we're saying that we always have to rule out if there's a medical reason why a patient may be having a behavioral problem. So it could just be that they're acting inappropriately because their blood sugar is too low. Okay, their skin gets pale, sweaty, just like they're in shock. Not that they are, there's no shock problem here. But again, since adrenaline, we said before, is secreted into the bloodstream to try to help the person, adrenaline will always make your skin cool, pale, and sweaty because it clamps down on the blood vessels. Again, they're tachycardic because of the adrenaline. They're breathing fast because of the adrenaline. So those three things, the pale, sweaty skin, what's called diaphoresis, the tachycardia, the rapid breathing, are all because of the adrenaline release. The adrenaline is released in response to the body realizing that the blood sugar is low as an emergency. The snoring breathing they may have, snoring respirations, is just because they're not fully conscious. And we said that if you're lying flat and you're not fully conscious, your tongue relaxes and partially blocks your airway, and the sound that makes is snoring. And yes, they can have seizures, because anytime the brain is not getting what it needs, you can have a seizure, but it's a very rare sign and a very, very late sign. Okay, so what's the problem with hypoglycemia? Well, again, the cells of the body are starving. So that includes the cells of the brain, right? I said that we don't need insulin to get sugar into the brain cells, but the problem here is not an insulin problem. The problem here is a sugar problem. So even though you probably have adequate levels of insulin in low blood sugar emergencies, it doesn't help anything because there's no sugar, okay, getting in to be able to be brought into the cells. So the brain cells are damaged and dying. They have an altered mental status, which means they could fall and hurt themselves. They could be unconscious and vomit and aspirate. And, there are diabetics whose blood sugars are so low and they're not found in a short amount of time, they could actually suffer permanent brain damage. Okay, so it's, diabetes is a very dangerous problem, but again, with better management as the years go on, we see less and less of the emergencies and stuff like that. Okay, so that's the low blood sugar. Now we're going to talk about the high blood sugar. So before we had hypoglycemia, right? HYPO, which is always low. Now we have hyper, which is high glycemia. Okay, so this is high blood sugar emergencies. So the typical reason why people's blood sugars go high is that they are a diabetic. Okay, they're supposed to be taking insulin and they don't take it. So now what happens is that the sugar cannot get out of the bloodstream. They're still eating, so they're still getting sugar into their body, into their bloodstream, but it cannot leave their bloodstream and get into their cells because there's no insulin present. Okay, and we said that the only way sugar could leave the intestinal tract, leave the bloodstream and get into the cells is if insulin carries it in. So then probably the 90% reason why somebody has a high blood sugar emergency has to do with not enough insulin. Okay. Now, infection can definitely cause the body to kind of get out of whack and not work properly. So we'll talk about that in a second. But the emergency, okay, when somebody's, so hyperglycemia just is the term for high blood sugar. The emergency that somebody suffers when their blood sugar goes high is called diabetic ketoacidosis. Now, pretty much everybody just calls it DKA because it's easier to pronounce, okay? But the true term diabetic ketoacidosis, what basically means is that the body is actually becoming acidotic. You remember we've mentioned a few times now that the fluids of our body have a pH balance, have a certain level of acid and a certain area of level of base in it, and that's called pH balance, just like when you're testing the water in the pool. So when this diabetic goes into this emergency, they develop an acidosis and they throw off that level of their pH, their management of their pH. Now, I guess the question should be, why does this happen? So I'm going to explain why it happens, but they're not going to ask you on the test. Okay, why it happens. So when your body realizes, okay, that the blood sugar is dropping, okay, I'm sorry, the opposite. When your body's realizing the blood sugar level is rising in your bloodstream, but not in your cells, right? Because in this situation, the blood sugar is rising, it's hyperglycemia in the bloodstream, but it can't get into the cells because there's not enough insulin. So the cells signal to the brain and say, we're starving, right? And the body says, well, there's plenty of sugar in the bloodstream. Okay, I can understand why you're not starving. The reason they're starving is because there's no insulin. So what the body tries to do now, okay, is make sugar, produce sugar from other sources. Even though there's plenty of sugar in the bloodstream, it has no way of getting that sugar from the bloodstream into the cells. So it starts to try to produce sugar from other sources. And what it actually starts to do is breaks down fat, because fat is a storage form of sugar, right? We get fat when we eat too much. So it's basically a storage form of sugar. And when it breaks down the fat, the process of breaking down the fat is not a very precise, clean process. And there's a lot of acid that is released in that process. So what happens is, because there's not enough sugar getting into the cells, it resorts to breaking down fat. And because it's breaking down fat, it makes the body's fluid levels very acidotic. And again, for us to stay alive, we have a very narrow range, pH range to stay alive in, and it's throwing that out of whack. It's making us very, very acidotic. Okay, so what are the causes of why somebody has diabetic ketoacidosis? Why does their blood sugar rise very quickly? So when they say stress, it's not really the stress of, say, a job or something like that. We're talking that somebody has a severe emotional problem, a death of a close person, job loss. I mean, something very, very stressful. The number one reason that a diabetic goes into diabetic ketoacidosis is that they get a cold. They get a viral or bacterial infection in their body, and it kind of throws things out of whack, okay? Or it could just be that they're eating too much sugar, right? They're eating more sugar than they should, and they're not taking more insulin to compensate for the fact. But out of all of these, the number one reason that this is a known diabetic, right? And they're having a problem where their blood sugar is rising. The number one cause is that they have a sickness. And out of the number one sickness, it's usually an infection. So it could be in a woman, a urinary tract infection, much more common in women than men. Okay, but really any infectious bacteria, virus, or anything like that will cause a diabetic's blood sugar to start to rise. And if they don't take insulin in response to that, their sugars will start getting to a very, very high level. Now, again, it takes days, okay, to sometimes a week or two for it to really get to the level where they have signs and symptoms, okay? And then they have some very classic signs. They get hungry and thirsty, okay? Now, we can understand why they get hungry, right? Because the cells are saying we don't have enough sugar. There's plenty of sugar in the bloodstream, but it's not getting into the cells because there's no insulin. So the cells don't care. All they know is they're starving. So they send a signal to the brain that they're starving, which sends a signal to the patient to think that they're hungry. Okay. The thirst comes in because when somebody's acid level starts to rise in their body, one of the ways the body tries to get rid of it is by causing you to urinate. So in a person having a diabetic ketoacidosis emergency, one of the things the family is going to tell you, besides the fact that the patient's eating a lot, is that they're peeing a lot, they're urinating out a lot, and because they're urinating out a lot, they're getting thirsty and they're drinking a lot. Okay, so there's some very classic signs. So there's the extra eating, extra drinking, and extra urination. What actually happens, typically first is that they start to urinate, and because they urinate so much, they have to drink, and then the eating comes along after that. So it's the three classic signs that you see. Now, what happens with it is that because they're urinating out so much, they get dehydrated. And again, because of the breakdown of fat to make energy, they become acidotic. So interestingly, what actually kills somebody in a diabetic ketoacidosis emergency is not the high blood sugar, is more of the dehydration and the acidosis, okay? Which on the test, they're going to say to you, you're not sure if a patient's having a low blood sugar emergency or a high blood sugar emergency. Can you administer sugar? Okay, and they're going to have a patient that's, conscious, because we can't give somebody sugar through their mouth if they're not conscious. So the answer would be yes, because if it's a low blood sugar emergency, giving them the sugar is going to actually help them. If it's a high blood sugar emergency, giving them sugar is actually going to raise their sugar higher, but since the sugar is not really what's killing them, we don't care. So we would rather treat the low blood sugar emergency patient, okay, purposely, and then accidentally, incorrectly treat the high blood sugar patient emergency with the sugar. Okay, so that's really, what it comes down to. You're going to be able to very simply tell the difference in a couple seconds by the signs and symptoms. Okay, and again, we can also use glucometers. We can also use the meters to check somebody's blood sugar. Okay, so again, in somebody who has diabetic ketoacidosis, it's a very slow onset. Okay, but as they get closer to the being into about a week level, they do start having altered mental status. They are going to get very dehydrated, so they can have that hypovolemic shock type of problem. The dehydration, again, is from the excess urination trying to rid the body of the acid that's developing. They get a very classic respiratory pattern called Kussmaul, named after a doctor, Kussmaul respirations, where they have deep, rapid breathing, almost panting. And that's, again, trying to blow off the extra acid by reducing their CO2 level. In other words, they're breathing deep and fast, trying to remove carbon dioxide. And carbon dioxide is a different acid in the body, but they're just trying to compensate for the high acid level because of the diabetic ketoacidosis. They may have a fruity or nail polish-like smell on their breath, okay, because it's called diabetic keto. Ketones are acetones, are a weak acid, so they may have that smell on their body. Okay, they call it as a fruity smell or a nail polish type of remover smell. And then they get what's called the 3 polys. So polyuria is a term for excessive urination. The reason they're urinating is to get rid of the acid. Polyphagia is excessive hunger and eating. Again, that's because the cells are screaming for food, because there's no insulin to get the sugar that's in the bloodstream into the cells, so the cells sense that they're starving. Okay. And then the polydyspia, the excessive thirst and drinking, is because they were urinating out so much, making themselves dehydrated. Now, interestingly, what do they eat? So they don't eat a well-balanced meal. They're craving sugar, right? They don't know they're craving sugar. Their brain is telling them they're craving sugar. So they tend to eat cakes and cookies, sodas, and soft drinks and fruity drinks and stuff like that, because their brain is telling them, right? The cells of the brain are saying, we need sugar. Okay, because the cells don't realize there's plenty of sugar in the bloodstream, and the problem is really an insulin problem. Okay, so what do we do for these patients? Okay, so the first thing again is, they can be, I don't want to say violent because they're not intentionally violent, but they can be flailing their arms around and stuff like that. So just, make sure that you're not going to, get hurt or anything like that. And then we're going to do our assessment and try to determine, is it a diabetic problem? And if it is a diabetic problem, is it a low blood sugar emergency, hypoglycemia, or high blood sugar emergency, hyperglycemia, diabetic ketoacidosis? Okay, and then again, we're going to go by the signs and symptoms and stuff like that we're going to look for. Again, family may tell you that there's a history of diabetes. The patient may have that medical alert tag on, or you may see insulin or different pills that you could look up and see what it's being used for. Okay, EMTs in New York State are allowed to use blood glucometers, which is a device that measures a patient's sugar level. Okay, the problem with that is, you come to someone who you don't know and you check their sugar level, right? So a normal sugar right now in all of us is probably somewhere, 60 to 80 milligrams per deciliter, right? That's about, if we ate maybe 100 So that's a normal level, but we're not diabetics. So the issue is we come to check to someone and, you know what the normal level is because I just told you, but you don't know what's normal for that diabetic, right? Because their sugar was never really going to be normal. So the only way to know what you're looking at when you get a reading on a diabetic is to know where their sugars have been over the last, say, 24 to 48 hours. So there's only two ways to find that out. So some patients write it down on a piece of paper. They write down the time and what their sugar level was. But the machines themselves, which I'll show you in a second, actually have memory, and there's a way of scrolling backwards. Now, the reason I bring it up is, let's say you have a diabetic, partially altered mental status, not totally conscious. You come and you check their blood sugar, and you find their blood sugar to be 90. So you say, well, then that blood sugar is a normal range, right? It's between 60 to 100. Okay, so it's in a pretty much normal range. So I don't understand why they're having this altered mental status. What you're missing is that maybe because they've been a diabetic, maybe their blood sugars have been running 200-300 over the last month. Okay, and now even though it's 90, which is normal for us, that's a not diabetic, it's not normal for that patient if they've been running 300s and now it's only 90, it's way too low for them. So that's called a relative hypoglycemia, which means relative means that it's not actually hypoglycemia in a healthy person, a non-diabetic, but for that diabetic that was living in that high sugar environment for weeks and months and stuff like that, because now the sugar is low, okay, for them, they're having the same altered mental status that somebody like us who's not a diabetic would have if our sugar went below 40. So you get that concept so what I'm saying to you is a blood glucose monitor is a okay device, but if you're getting a normal reading and the patient has an altered mental status, you have to still assume it's a diabetic problem unless you know what that patient's blood sugar is. Obviously, if the patient's unresponsive and you're getting a blood sugar of 20, you know what the problem is, okay? Just in case I forget, these machines have limits to what they could measure, right? So the only way you'll know what the limits are is to read the manual with each one. But pretty typically is that when it goes below 40, the blood machine will not print out a number. Will just tell you LO, low, which means it's below 40. Some machines will do that at 20. That's why you have to read the owner's manual. And again, if the sugar goes over 400, it's not going to tell you a number after 400. It's just going to say HI for high. And again, some of them do 200 or 300. So you have to know each manual, what the range is that's capable of checking the sugar and stuff like that. Okay. So I see that some people asked some questions. Okay, so let's go see what the questions are. Okay, so are there any cases where a patient with type 1 diabetes can recover? So I would say no, but again, they're experimenting with all different types of treatments as far as kind of tricking the pancreas to turn back on the ability to make insulin. But just as an average thing, I would say the answer is no. Once you have that diagnosis of type 1 diabetes, you're going to become insulin dependent unless they invent some, miracle cure type of thing. Okay. So somebody wrote, or somebody answered the question for the other person, wrote never, because the pancreas isn't producing insulin, which is correct, right? Unless you can trick the pancreas into starting to produce insulin again, it's not going to, solve the problem. So that is correct. Does DKA happen on a fast day? So no, because on a fast day, you're not eating. So your sugar levels can't go high. So what happens on a fast day is your sugar levels start to drop. And if you're going to have an emergency, you're going to have hypoglycemia, low blood sugar level, because you're just not eating enough. Remember, we said one of the causes of a low blood sugar emergency, right? Let's go back to low. Okay, would be, go one more, not eating enough. Okay, which is really why diabetics, probably should not be fasting. Okay, because it's really not going to be a good outcome either way on a diabetic on a fast day and stuff like that. So there's always going to be some type of issue. When I was first learning to become Jewish, it was my first Yom Kippur. I actually don't even think I probably wasn't even Jewish yet. No, I definitely wasn't, because I converted on Shavuos, so I wasn't even Jewish yet. But anyway, I was davening in shul. I used to daven in Beis David in Muncie, and this old-time Hatzola member. His name was Shimon Mendelowitz. I was staying by him for Yom Kippur, and he somehow or another, they knew that he was on Hatzola, and there was the Rebbetzin Rebbe down on Old Nyack Turnpike, and this is when he was already sick. So they decided that he should fast, okay, but I guess he was like a borderline diabetic. So somehow or another, I got drafted into starting an IV on him and hanging a bag of sugar water on him, so that he would be, quote, fasting because he wasn't eating orally, but his sugar would not get dangerously low because of the fact that he had the IV running into him and stuff like that. So that was probably kind of like a little bit of a workaround. But it got him through at least that Yom Kippur. I didn't ever do it again except for that first one. Does somebody have a question? Okay. Okay. So yeah, on a fast day, it wouldn't be probably DKA. Okay. That's why most diabetics don't fast unless their sugars are well controlled. Correct, right? Definitely not. Okay. And then somebody's complimenting. Okay. So yes, it would be very, very hard for a diabetic to, get through a 24, 26 hour, fast. It would be, very, very hard to do it. Okay, so now let's compare, well, actually, let's talk about blood glucose members, but there's some place where I was comparing the two emergencies. Where is it? Oh, here it is. Okay, so it's going to come up in a second. Okay, so blood glucose meters, we call them glucometers. Okay, so a blood glucose meter. So what it's basically doing is measuring the amount of sugar in the bloodstream. We'd like it to be able to measure and tell us what the level of blood sugar in the cells is, but there's no technology that can do that. Okay, so really when we get a blood sugar reading, all we're knowing is that the sugar that's in the bloodstream, and without insulin to bring it from the bloodstream into the cells, it's kind of not a totally accurate number. It's used by patients in their homes to check their blood sugar periodically, although that technology has even been surpassed now because that involved a finger stick. So now there's people who have devices on them called constant glucose monitoring devices, where it's basically kind of like that insulin pump, okay, where they have a little tiny needle under their skin that goes to a machine that's strapped to their body, and that machine sends a reading, okay, to their smartphone, and it tells them with a press of the button what their blood sugar is at any time they want to. It also monitors their sugar, so if it goes below a certain number, probably say 60, okay, it would start to alarm and tell them to eat. And if it goes above a certain number, probably 180, 200, it would tell them that their sugar is starting to rise too high and they probably need to take some insulin to get that sugar back down to a normal level. Okay, so that's, again, probably something in the last couple of years, so those people do not have glucometers, or maybe they have glucometers as backups, and they don't have to do a finger stick to check their blood sugar. Again, they just press a button on their smartphone and get a reading. I'm sure they have to change out the needle that's under their skin, sending the signal to that phone, periodically, just from a cleanliness standpoint, but they're not sticking themselves multiple times a day to check their blood sugar. Okay. So we are allowed in New York State to use glucometers, okay, as EMTs. It requires you, to have training on them, and it requires the agency to get permission to use them. But you are allowed if the agency you belong to has filed the correct paperwork and stuff like that. Okay, so a normal blood glucose level in a non-diabetic, because again, in a diabetic, you'd have to know where they've been running to know what's normal for them. But in us right now, probably 60 to 80 is the average. And if you've eaten somewhere 60 to 100, okay, is a normal blood glucose level, okay? In somebody who's a diabetic, you have to find out what they've been running at, right? What's their baseline been over the last couple of weeks to get an idea of what's normal for them. Okay, so again, they're just kind of showing you that they're going to use, that's the glucometer. Okay, you need a lancet or something to prick their finger to get them to bleed. And there's a test strip that goes into it and stuff like that. So it's something you really have to practice hands-on. And again, it's something, once you get into the agency, you're going to work out because there's so many different kinds of them that they will practice with, the ones they want. Okay, so again, blood sugar levels below 60 start to move towards hypoglycemia. Definitely when they go below 40, people are going to start having signs and symptoms, okay, of, and again, we're talking in this situation, probably both the diabetic and the non-diabetic, right? Once your sugars start getting kind of low, you're going to start definitely having some signs and symptoms, okay? And then on the high side, by book definition, over 140 milligrams per deciliter is the term for hyperglycemia, meaning high. But people who have high blood sugar levels, okay, like when they have diabetic ketoacidosis, they could be over 1,000, right? So, 140 is not great, but when you're talking over 1,000, 140 doesn't sound too bad, okay? So, that's towards the high level and stuff like that, okay? Now, most of glucometers, again, they will have a range that they can check in. So some ranges are on a low side would be 20, 10. We have ones out there, 5s now. It's something you have to read in the manual to know. But if all it's saying is that the calibration on that machine doesn't allow it to go below a certain number and be accurate. Okay, so when it goes below that number, you're just going to get an LO or LOW coming up on the screen, which tells you, again, if you've read the manual, that the number is below a certain level. And the same thing, if you get a high or HI on it, it means the number's gone above a certain level. So these machines, again, are not hospital quality machines. They're homeowner versions of the machines. I mean, they're very good. They're FDA approved, and stuff like that. But they have a certain range that they're calibrated to check. And if it's above that, they'll just give you that message of high. And if it's below, it'll just give you that message of low. So when you open the glucometer kit, you have the actual device. Inside this container are the test strips that plug in over here and that the drop of blood goes on. You have an alcohol prep to clean their finger before doing it. And these are called Lancets, which basically there's a needle hidden behind a spring. And it's a way for a patient to check their blood sugar without actually having to physically take a needle, uncap it, and stab themselves. So what they basically do is they twist off, and everyone's different. There's a lot of different ones. They twist off this little blue stick here, okay, and that uncaps the needle that's inside here, so you don't really see it. And then they press this white thing down on their finger. They press this blue button. A spring drives the needle into their finger, and then they get a little drop of blood that they put on the tip of the test strip over here. Now, one thing about wiping the finger with alcohol, everybody does it, okay, but alcohol is sugar, right? If you know anything about what alcohol is sugar. So that if you wipe their finger with alcohol and then immediately proceed to check their blood sugar, it's going to be abnormally high. So there's a couple things that you would do to make it a little more accurate is that, you can wipe their finger if you feel you need to. Again, most patients don't wipe their finger with alcohol every time they check their blood sugar. It's really just something that we kind of do because, I don't know why we do it, to be honest with you. You probably shouldn't. But if you're going to wipe it down, I would then take a sterile 4x4 or, something and wipe off the finger of the alcohol. Okay. And then when you actually prick the finger and get it to bleed, I would take that 4x4 and wipe off the first drop of blood that comes out. And then the second drop of blood that comes out, I would use for your sample to check. Okay. Because the first drop of blood is probably contaminated, with the alcohol that's on the fingertip and stuff like that, where the second one would be considered, a cleaner sample to be able to check. Okay. And if we have time, I'll get my hands on one and we could try to, practice a little bit the next time you guys do skills. Okay. So now what do we do for these patients? So if we suspect somebody's blood sugar is low, they need sugar. Now, the problem is that we cannot give them sugar if there's any chance that they could choke on it, right? Because we don't want to cause them to aspirate it. So if we get there and they're still capable of swallowing without any chance of choking on it, then by all means, we can give them some sugar. Now, we carry tubes of very concentrated sugar that we can give to someone. We don't have to cook a meal or anything like that to get their blood sugar level up pretty quickly. Okay, but again, you can't squirt that in somebody's mouth who's unconscious or has an altered mental status because you're afraid that they're going to choke on it. Okay, so that's called oral glucose. It comes in a tube that kind of looks like a small toothpaste tube, and it's just, instead of toothpaste, obviously just concentrated sugar and stuff like that. Okay, so again, we use oral glucose in people who expect to have a diabetic emergency, and we expect it to be a low blood sugar emergency to be able to do it. Okay. again, they say patient squeezes the glucose in their mouth because you want to make sure that they are awake enough to be actually able to swallow it. So if they are able to, handle the tube and squeeze it into their mouth, we assume that they're awake enough to be able to actually handle it. Okay. Now, years ago, it was acceptable on people who are not that awake to actually squirt some on a tongue depressor. A tongue depressor is that wooden stick when the doctor wants to look to the back of your throat to do like a strep test and stuff like that. That's a tongue depressor. So we used to squirt it on the tongue depressor and stick it inside the patient's mouth up against between their teeth and their cheek to let it get absorbed slowly. But now we're not allowed to do that because there was, I guess, situations where patients actually choked on it. So the rule basically is that the patient has to be capable of administering it to themselves. Okay, we probably massage that a little bit by helping them, but technically they're supposed to be able to handle it and squeeze it into their mouth and stuff like that. So that's what the instant glucose looks like. Okay, and you basically hand it to the patient and have them start squeezing it into their mouth. There should be no side effects, but I always tell every class, I had a situation where I gave somebody oral sugar. The patient was their sugar was a little low. They were still awake. I actually got there. They were trying to eat an apple, but weren't having much success in biting into it because, their blood sugar was so low and they were so weak and everything. So I gave him the tube of sugar to take, and he was starting to take it. He was starting to wake up. And as they start waking up more, they actually squeeze it harder and start giving themselves more of the, of the sugar. But all of a sudden, the guy starts screaming, and he was holding his head going, oh, like screaming really loud. And I'm like, oh my God, like, what did I miss here? And I couldn't figure out exactly what was going on with him. I was trying to get him to talk to me, but he was just screaming. And then all of a sudden I heard he started screaming, my teeth, my teeth. And what actually happened was he must have had a cavity or a loose filling or something like that. And did you ever bite into like a chocolate bar or a candy bar and the sugar makes its way into the filling and it hurts like crazy? So these tubes are probably like 100 candy bars. So all I could assume is that the amount of that sugar, that concentrated sugar paste, somehow made it into a cavity, and that's where his pain came from. Because we gave him a little water to drink, and he felt fine and was awake and everything like that. And it was probably just that it was a loose filling or stuff like that. Okay, so 1 tube of sugar should be pretty good for all of them. And then what you would want to do after they eat that tube of sugar is to recheck their blood sugar, see what number we're at. Compare that number to where they were prior to having this low blood sugar emergency, and then probably encourage them to, eat a regular meal, because this is like eating, artificial candy bars. So they would probably be better off eating a normal meal with some carbohydrates and proteins and stuff like that. So you kind of encourage them to eat a normal meal after that, and to then recheck their blood sugar again after that and see if they need some insulin. In other words, now they may have raised their sugar a little higher than it should be, so they may need a tiny little bit of insulin. Okay. I wouldn't give them a second tube of sugar, okay, on a BLS level without getting a second blood sugar and then calling medical control and saying, do you want us to give them a second tube of sugar or not? So over here, we're going to compare, right, because this is what probably the questions everybody's having right now. How do we know the difference between a low blood sugar problem or a high blood sugar problem? So I went through like all the different signs and symptoms that you would see here. So the first thing is onset. So hyperglycemia, diabetic ketoacidosis, a high blood sugar emergency, slower onset. Slower means days to up to a week to develop. Okay, where hypoglycemia, once the sugar gets below a certain level, right, and that level depends on each diabetic's normal blood sugar level, they're going to have an altered mental status. So hypoglycemia typically happens in minutes. Hyperglycemia typically happens in days. So that's the first thing. Okay. And that pretty much makes it easy right off the bat. If the story is he's been sick and getting, more and more confused over a couple of days, and the family tells you he's eating a lot, drinking a lot, and peeing a lot, that's probably more towards the diabetic ketoacidosis hyperglycemia. If somebody says to you, all of a sudden he started to become unconscious, snoring, and he's, sleeping, and he's a diabetic, that's probably more towards the hypoglycemia. Okay. Now, skin. Okay. The hyperglycemic patient early on, for the most part, typically has warm, dry skin. Okay. If they have an infection as the cause, remember one of the things we said that throws their sugar out of whack, if they have infection as a cause, their skin is definitely going to be warm. Okay. Because it's high. Now, I know it's 9 o'clock. I'm going to give you a break in a second. Okay. Now, hypoglycemic patients, okay, typically have skin resembling somebody in shock. They have the cold, clammy, diaphoretic skin because, again, we said that one of the hormones that's secreted in the body trying to compensate is adrenaline. And adrenaline is going to cause the blood vessels in the skin to clamp down and move that blood from the skin towards the vital organs. So they're going to get that classic cold, pale skin, okay? Now, in the high blood sugar emergency, we said they have that acetone or fruity-like odor on their breath, okay? And they may be breathing very deep and fast, okay? That cosmal respirations that we were talking about. Okay, the other one, the diabetic ketoacidosis, usually has a history of being sick for a couple of days, and they present what they call the 3 polys. Polys means a lot of something. So again, they're urinating out a lot to get rid of the acid. Because they're urinating out a lot, they drink a lot to replace the fluid, and they eat a lot because the brain is signaling that their blood sugar level is low, and it's tricking the person into wanting to eat. This is just showing you what an insulin pump looks like. So there's 2 devices here. Underneath this is a tiny little needle under the skin. And this is sending a Bluetooth signal to the machine, telling it what the blood sugar level is, okay? If the blood sugar level is starting to rise, the machine will squirt insulin through this tube under another little needle here and give the patient insulin. So this is what an insulin pump does, okay? There are some patients that just have this, and that on their smartphone, they'll get a signal of what their blood sugar level is, and they can then give themselves insulin if they need to. But the total package would be the monitoring plus the pump to actually give them insulin if they need it, right? So that's the total package. Okay, so let's take a break, and then we'll come back in a minute and talk about, just review all the diabetes, because I know it was a lot of information in a short period of time. So it's 9:06. Come back about 9:15, 9:16, and we'll pick up. Okay, so take a break, stretch your legs, use a bathroom, get some water. Oh, very good. So that's called hypoglycemia, right? So now we have to say what causes hypoglycemia. So we have to go through these questions. So if we go through too much insulin, so we have a lot of insulin, insulin reduces blood, right? I'm sorry, insulin reduces sugar. It allows sugar to come into the cells, so it reduces it. So that's a possibility, right? That would be a low blood sugar emergency. If there's too little insulin, then there's no sugar leaving the bloodstream, so that would be a high blood sugar emergency, which is a slow onset. Okay, if there's excessive food intake, that means they ate too much. That could not be a low blood sugar emergency, right? That would be a high blood sugar emergency. And excessive fluid has nothing to do with anything, right? That's just a distractor. So the first thing you have to do with this question is say, read this part, a diabetic emergency with a rapid onset. So then you could say, okay, they're asking me about hypoglycemia, because I know that hypoglycemia has a rapid onset. So then you have to say to yourself, how does hypoglycemia occur? So you'd say, okay, it happens when there's not enough food coming in, okay, or somebody took too much insulin and bottomed out their sugar, right? They got rid of all their sugar. So you say, okay, does there anything that says too little food? Well, no, nothing says too little food. Is there anything that says too much insulin? Yes, number 1, okay. 54, sugar passes from the blood, okay, to the cells with the aid of a chemical substance known as. Okay, so again, if you go through it, glucose is sugar, dextrose is sugar, oxygen, okay, doesn't help. We know insulin, sugar get in, so the only answer then would be insulin, right? And then the last one, whoops, here we go. Which of the following results from hypoglycemia? So again, low blood sugar. Okay, so tremors caused by excessive glucose in the skin. So we've never mentioned the word tremors. Tremors is shaking, right? Okay, and if it says excessive glucose, okay, so hypoglycemia means too little. Excessive means too much. So that can't be right, okay? What the person here probably was doing was crossing off answers that can't be correct. Drowsiness, confusion caused by lack of glucose to the brain. So that sounds pretty good so far for hypoglycemia, right? There's not enough sugar, right? So because it's low, hypo means low, so that's probably right so far. Dry skin caused by polyuria. Polyuria is the term for excessive urination. Okay, that typically happens in the high blood sugar emergency, not the low blood sugar emergency. And fruity odor to the breath caused by severe acidosis, again, is sign of the high blood sugar emergency. right? That was that Kussmaul breathing, the acetone-like odor. So the only one that has to do with a low blood sugar emergency would be number 2, drowsiness or confusion caused by lack of glucose to the brain. Okay, and let's look at one other set of questions. We'll do more on what's a Shabbos. Okay, so this one says a sudden onset altered mental status with a history of diabetes will exhibit which of the following? So again, they're talking about hypoglycemia, right? Sudden onset, okay, altered mental status with a history of diabetes would be a low blood sugar emergency because it's sudden. So it'll be low blood sugar, which is hypoglycemia. So slow pulse and warm, dry skin. So we said that typically somebody who has a low blood sugar emergency, because the adrenaline secreted in their bloodstream, will have a rapid pulse and cold, pale, sweaty, clammy skin. So number 3 is the right answer, rapid pulse and cool, clammy skin. Okay. And now we have a 28-year-old patient presents supine on the floor. That means on their back, unconscious, unresponsive, with snoring respirations at 6 per minute. Bystanders report the patient is a diabetic, takes no medications, may have ingested heroin half an hour ago prior to EMS arrival. After opening the patient's airway, the EMS provider should. Okay, so let's go through it. So what do we know? We know he's unconscious and he's not breathing enough times a minute to stay alive, right? 6 times a minute. Okay, so we have to see now, they threw 2 other things at us. They told us he's a diabetic who happens to take no medication, which again is pretty rare. Okay, and he's possibly has heroin on board. So let's go through it and say. So we've opened his airway. It says administer oxygen via non-rebreather face mask at 15 liters per minute and administer syrup of ipecac. So we know right off the bat that one, we said when we did poisoning that we never give syrup of ipecac anymore because it makes a patient vomit. The other thing is we would never give something to someone who's unconscious to make them vomit, right? So this is a stupid. Does he need oxygen? Yes, but a non-rebreather would not be the right way because he's only breathing 6 times a minute. We have to actually ventilate him, right? Administer oral glucose and administer oxygen via non-rebreather at 15 liters per minute. Again, we can't put anything in someone's mouth who's unconscious, so we can't give him oral glucose. And this is not the right way to give him oxygen because he's only breathing 6 times a minute. Okay, administer oxygen via non-rebreather at 15 liters per minute. Again, he needs to be ventilated. So the right answer here is insert an airway adjunct and ventilate with 100% oxygen using a bag valve mask, right? Because at 6 times a minute, if you just strap a mask on his face, he's not going to be getting enough breaths per minute in. So he needs to be ventilated. Okay, and then 47. A patient with a history of diabetes has an altered mental status due to a diabetic emergency. The EMS provider should. So question 1, okay, administer a sugar concentrate. So that's again that oral sugar. Let me just mute everybody. Okay, so administer a sugar concentrate if there's no danger the patient will aspirate. Remember, aspiration is the term for choking on something and getting into your lungs. So this doesn't sound like a bad choice right now, okay? It's because they're saying as an altered mental status, but you're saying I would only give him the sugar if he's awake enough not to choke on it. Okay, encourage the patient to take an insulin solution orally if there's no danger the patient will aspirate. So looks like here somehow the test got a little screwed up because there's no choice. Oh, I see it. So no, this aspirate should be going after will. And then this is number 3 and this is number 4. Okay, so it kind of screwed up a little bit. Okay, so the first one doesn't sound bad. The second one makes no sense because there's no such thing as an oral insulin solution, nor do we carry insulin on ambulances or paramedic trucks, right? So we've never talked about giving a patient insulin. Okay, number 3 would be administer a sugar concentrate by mouth only to an unconscious patient. Okay, so we never give anything by mouth to an unconscious patient, right? We said that already. And then number 4 would be defer all treatment and transport the patient to the hospital. Okay, so then why we don't, for that, we could just put them in an Uber, right? I mean, if we're not going to help them at all, then why are we there? So probably the most correct answer would be administer a sugar concentrate if there's no danger that the patient will aspirate. Okay. 48, a diabetic emergency with a rapid onset is due to, so we had this on the other test. And again, rapid onset is low blood sugar emergency, and low blood sugar emergency is only caused by one of 2 things, pretty much, which would be too much insulin, because insulin will reduce the level of sugar in the body, or not taking enough food. So the only choice there that would be correct is too much insulin. Let's see if there's any more. Which of the following results from hypoglycemia? Oh, we did this one also. Okay, so that would be drowsiness or confusion caused by lack of glucose to the brain. Okay, because everything else has to do with the high blood sugar emergency. Okay, and then we'll go over, all the other questions on Motzei Shabbos and stuff like that. Okay, so now going back to what we're doing.
Frank.
Yes.
When somebody is hypoglycemia, the sympathetic system kicks in because the adrenal.
When somebody is hypoglycemic, as you say, when their blood sugar is low?
When the blood sugar is low, the sympathetic system kicks in.
Right, and it releases adrenaline, yes. And that's what gives them the tachycardia. That's what gives them the cold, clammy skin and all that stuff. Okay? Okay, so anybody have any questions on the diabetes? So let's just review real quick. We said that in diabetes, okay, let's just talk normal maintenance of blood sugar in a normal healthy person. That what basically happens is that the body monitors the level of sugar in the cells. The cells are telling the body how much sugar is in the cells. If the level of sugar in the cells drops, then insulin will carry sugar from the bloodstream into the cells to replenish the sugar that it needs, okay? The sugar gets into the bloodstream by normal digestion, but can only leave the bloodstream and get into the cells if there's insulin present. Then we said there's 2 types of diabetes. In type 1 diabetics, which again typically happens at a young age because we call it juvenile onset diabetes, the cells in the pancreas that make insulin do not work, okay? And those people need to take artificial insulin to be able to stay alive, okay? In the other type of diabetes, type 2 diabetes, that's typically is adult onset, and that is brought on by obesity being too heavy. And the problem there is that there is insulin being produced, but the cells become resistant to the insulin and do not let the insulin carry the sugar into the cells. And that is because for years and years and years, the patient's cells of their body were exposed to high sugar levels because of the chronic obesity. Okay. We said that in the type 1, they have to take insulin. They may also take some oral medications to help the insulin work better. And in type 2s, they definitely will take oral medications to try to reduce that resistance of the insulin. And if it doesn't work, they may also have to take insulin shots themselves. Then we said there's 2 types of emergencies. There's a low blood sugar emergency called hypoglycemia, HYPO glycemia, low sugar. The typical causes of hypoglycemia would be taking too much insulin or not eating enough. And then we said there's some other rarer things, which would be exercising too much or having a stomach problem where you're vomiting or have diarrhea and you don't have time to absorb the sugar out of the food into your bloodstream. And that in a low blood sugar emergency, it happens very quickly, okay? And the body senses a true emergency occurring, and that it secretes adrenaline into your bloodstream to try to break down other forms of sugar we have in our body and raise the blood sugar. And the side effect of that insulin getting into the bloodstream, that adrenaline getting into the bloodstream, is that the patient gets tachycardic, patient gets tachypnic, which means they breathe very fast, and their skin gets cool and clammy, okay? The only treatment for a diabetic with a low blood sugar emergency is to give them sugar. But again, it depends on whether or not they're awake enough for us to orally give them sugar, or we just transport them to the hospital to have an IV and get sugar through the IV, or if the paramedics come, they can give sugar through an IV to wake the patient up. Okay. If we are transporting a patient and we can't give them oral sugar because, you know, they're too unconscious, I probably would put them in the recovery position so they don't vomit en route and aspirate their vomitus. You can put them on some oxygen. Again, if their pulse ox is normal, probably just a nasal cannula at like 2 liters. And the big thing there would just be to protect their airway if, God forbid, they should vomit while you're transporting them to the hospital. The hyperglycemia, the high blood sugar emergency, HYPER, hyperglycemia, is better described as diabetic ketoacidosis, right, DKA. And the most common reason why somebody goes into diabetic ketoacidosis is that they get an infection in their body. So they are a diabetic. They get an infection in their body. Because the body's fighting the infection, it's not doing a good job in controlling the sugar, and the sugar starts to climb. Okay, now also because they're sick, they're probably not paying attention to checking their sugars and taking their insulin like they should. And over a period of days, the sugar starts to climb very, very high, dangerously high. Okay, because there's not enough insulin in the body, okay, it can't get into the cells, so the cells are starving, just like with the low blood sugar emergency. Even though there's plenty of sugar, it's a high blood sugar emergency, but it's blood sugar, it's not cell sugar. So you still need the insulin to get it out of the cells into the bloodstream, and that's the main problem in diabetic ketoacidosis, that they're not taking their insulin, and that's what's causing their sugar to climb, okay? They get some very classic signs, which is the onset is very slow, usually preceded by some type of infection, okay? Their skin typically is warm and sweaty if they have a fever, right, from their infection. And then they have the deep, rapid breathing to try to blow off the extra acid that's being produced. That's called Kussmaul respirations. And they may have a fruity-like odor on their breath. That's called an acetone or fruity-like odor on their breath. And then they get the 3 polys, right? So they urinate a lot. That's polydyspia, right? Or I'm sorry, polyuria. They're trying to urinate out the extra acid in their body to lower their pH balance. Because they're urinating out a lot, they drink a lot because they're getting dehydrated. So that's called polydyspia. So they drink and drink and drink. And then again, because the brain cells are still kind of functioning because they don't need insulin to get sugar, so they're kind of awake. They're crying out, right, that the body's screaming for more sugar. All the other cells in the body are screaming for more sugar. So the person starts to eat. And again, they tend to eat foods with very high sugar levels. So that's called polyphagia. So that's the typical presentation. Again, low blood sugar emergency, rapid onset, high blood sugar emergency, slow onset, low blood sugar emergency, cool, pale, clammy skin, like shock, but they're not really in shock. And the high blood sugar emergency, they tend to be warm if they have a fever. And then in the high blood sugar emergency, the other couple things that they will say is that they have that deep, rapid breathing, the Kussmaul respirations, the acetone-like odor on their breath, and then the 3 polys. They eat a lot, they drink a lot, and they pee a lot. Okay. In the high blood sugar emergency, there's nothing in the world we could do. They need fluids and they need insulin. And even on an ALS level, we don't carry insulin, so we can give them some fluids on an ALS level, but we can't give them any insulin. So they need to get to the hospital, again, protecting their airway. Okay, so any questions on the diabetes? Okay. And again, we can go over more if we want on Saturday night. Okay, so go ahead. Somebody a question?
In general, diabetic, where does it lead to eventually?
Oh, good question. So I think we talked about this a little bit last night. So the disease of diabetes, okay, destroys the capillaries in the body, okay, makes the capillaries in the body start to break down and not work well. So what happens when somebody is a diabetic that's not controlled? In other words, you could have diabetes, and if you control your sugar, you probably won't have a lot of these problems. But if you're having variations of your sugar where it's going all over the place because you're not doing a good job in controlling it, you're not taking your medicines and eating properly and exercising and all that stuff, and you have fluctuations in your sugar, okay, what happens to it? So the capillaries are the blood vessels that give the cells what they need, right? So that means that pretty much every cell in your body is going to start failing. So the further away something is from the heart, the first it starts showing symptoms. So typically, in diabetics that are not controlled, they go blind. They have visual problems, okay? They tend to have wounds or sores or injuries on their skin that do not heal. The reason they don't heal well is because you need white blood cells, right, going to fight infection. And if you're not having good blood flow, okay, they don't work well. Nerve endings in their skin are not working well because, again, they're not getting blood. So when they bang themselves, diabetics bang themselves, they don't even know how bad it is, okay? They have problems with their kidneys, problems with their heart, problems with their brain, because, again, it's just the blood vessels are not getting everything they need to do it. So that's the long-term consequences of diabetics. They have a higher rate of heart disease. They have a higher rate of kidney failure. They have visual problems. They can go blind. They get infections that don't heal well. A lot of times they have to go to like wound care clinics and get hyperbaric medicine treatment to be able to get their wounds to heal. And if they don't heal, they get septic, which is the next thing we're going to talk about. So that's kind of the long-term consequence of diabetes. You know, we in EMS don't really look at the long-term consequences. We kind of look at the emergencies that we get called to their homes to deal with. And again, that's more of the quick low blood sugar emergency, probably 90% of the time. And then very rare, you know, less commonly, the high blood sugar emergency.
Frank, in other words, it could cause MI to me, correct?
Yeah. Well, the other thing that happens is that because their nerves are not sending the signals properly, because they're starting to break down, is, remember we said last night that certain patients can be having heart attacks and not feel the symptoms the same way. So we said the elderly patients because their nerves are breaking down, the diabetic patients because their nerves are damaged from diabetes. So yes, one, they have a higher risk of actually having problems because their capillaries are not working well. And two, they don't even feel the pain the same way because their nerve endings are not working well. So they have a double issue. Okay.
How about a stroke?
So, yes, but probably not. Again, it's blood vessels. Strokes are blood vessels. So yes, but it's usually more of a problem with infection, kidney problems, heart problems, and stuff like that. I have a general rule with diabetics myself, which is that if a diabetic calls us to the house, I take them to the hospital. I don't care what the problem is. I take them to the hospital because there's no way in the field to be 100% certain what's going on with a diabetic. They're the most confusing patients in the world to manage. So it's, you know, if they're calling you, they obviously sense something is not right, and I transport them to the hospital. You know, a lot of times they'll say, "You think I really need to go?" And I say, "Yes, you need to go. You know, with your diabetes, that it takes the littlest thing to get you very sick. It's better you get to the hospital, get checked out, and not have to stay overnight, right? Get stabilized before you get very, very sick, versus have to stay in the hospital and then have the risk of picking up a secondary infection or something like that in the hospital." So, you know, that's my basic rule. I don't, you know, I don't ever leave diabetics in the home. Okay, so somebody wrote, is there an injector that injects sugar? So I guess you mean like an auto injector. The answer is no. Okay, there's nothing like that. The reason why, very simply, is that if you were to inject sugar under the skin, right, like that's what an auto injector does. It's an intramuscular injection. It would rot the skin. Sugar in the skin would be very, 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 like, in other words, concentrated sugar like that we would have in a tube of oral glucose would cause a huge wound in the skin. In fact, it's one of the big dangers when we give people intravenous sugar is that if the vein, you ever see sometimes you get people get an IV and the vein blows, right? And they get a big bruise. So if they were getting a sugar infusion when that vein blew, they could have a big wound in the area where the blood was leaking out. So sugar is very damaging in high levels underneath the skin. So we never want to inject it under the skin or anything like that. Taking it orally, right, and then swallowing it into your stomach is the normal way we get sugar in. So then it's fine to do it that way, right? We take sugar into our stomach, goes into our intestine, gets absorbed by the capillaries in the intestine and gets into the bloodstream. That would be the normal way to get sugar into the body. So there's no such thing as a an auto injector of sugar. Okay, so anything else?
One more question.
No
Maybe
problem.
I've missed or I didn't understand the right way. So you mentioned before that, for an example, a hypoglycemic presents the same as shock, but it's not in shock. That means that it's not life-threatening. Like it's not going to go into a.
No. So when I say it presents similar to shock, I mean the skin. The skin gets cool, pale, and sweaty, and they get tachycardic, right? So that's kind of what we see in most of the shocks. So, but there is no problem with fluid. There's no problem with volume. There's no problem with pumping. It's just that the way we were designed, that when the body senses the blood sugar getting low, it releases adrenaline into the bloodstream. So adrenaline was always going to make your heart race, your breathing faster, and your blood vessel and your skin get cool and sweaty, right? So it just happens to be that that emergency hormone is one of the hormones that's secreted by the body when the blood sugar goes low to try to stabilize things. But it has nothing to do with any kind of the shocks that we talked about, right? The obstructive, the distributive, the hypovolemic, the cardiogenic. It has nothing to do with any of those. It's a completely separate problem that's just related to sugar. It has nothing to do with volume, with fluid, or anything like that. It just kind of looks that way. If you're just taking a quick glance at the skin, you would say, oh, you know, he's cool and pale, he's tachycardic, he's breathing fast. You know, that kind of sounds like the signs and symptoms of shock. And you're not wrong to say that, but in shock, there's a different reason. It's still adrenaline, but there's a different reason why the body's secreting adrenaline when somebody's shocky versus when somebody's secreting adrenaline when somebody has a low blood sugar emergency. And the low blood sugar emergency is trying to raise the blood sugar. In a shocky emergency, it's trying to compensate by increasing the heart rate and constricting the blood vessels. So just, you know, same hormone, but for different reasons.
So technically, you're not going to, if you're not treating it within a half hour, you're not going to go into irreversible shock and die.
No, but what's going to happen is your brain and your organs are deprived of sugar, so they're going to start getting, you know, injured. So somebody who has a low blood sugar emergency, time does matter. Okay, you know, so it is an emergency and they need to get sugar. So if you can't give them the sugar because they're unconscious already, you need to get them to the hospital as quick as you can so that they can get intravenous sugar. Or if the paramedics are coming to the scene, you know, they can start IV and give the sugar, you know, there. But it is an emergency. It's not like you have hours to treat this patient. I mean, every minute the brain is deprived, right? It's just like every minute the brain is deprived of oxygen, there's damage. It's the same thing. Every minute the brain is deprived of sugar, there's damage. So, I mean, again, it's not like the body's going to zero level, right? I mean, it's below what it should be, right? It should be 60 to 80, 60 to 100. It's down in 20s, but it's not zero. Okay, so I mean, you do have a few minutes to get them there, right? That's why people that are found in the home with a low blood sugar emergency usually recover. Okay, but again, they recover with having some cells that have died, right? I mean, our cells die and reproduce, but there are, you know, certain cells that don't reproduce. So, you know, and when you're having a low blood sugar emergency, all the cells need sugar. So it's not like you can say, oh, it's a skin cell and, you know, we have billions of skin cells. It doesn't really matter. So, okay.
Got it. Thank you.
Okay. Any other questions? Okay. I noticed that the texting of questions and the phone calls of questions during the daytime has dropped off. So I don't know if that's because I'm doing a great job teaching or you guys are actually reading your books a little bit. But, you know, if you're confused about something, you should call me. So somebody wrote, what is the blood pressure on hypoglycemia? So typically on hypoglycemia, the blood sugar is actually, blood pressure is probably fine, if not a little higher, because remember the heart's beating harder and faster. So the blood pressure may be a little normal or a little higher. But really what you should ask is what's the blood pressure in hyperglycemia and diabetic ketoacidosis? And there, because of the excessive urination, which way do you think the blood pressure goes? So if they're urinating out a lot of extra fluid, which way do you think the blood pressure goes, higher or lower? What do you think? Lower, right? Because in other words, they're basically dehydrating themselves. So if you're losing fluid from the body has to get fluid from somewhere to replace it, right? So it's going to start shifting fluids around and your blood pressure typically starts to drop. But again, most of the times it would be, you know, you're talking days into it before they would ever get to that standpoint. And at least in America, most patients are going to get to the hospital, you know, before days go by, right? As soon as the family starts to see the patient's peeing a lot and eating a lot and drinking, I mean, they know the patient's diabetic. So they know the things to look for. And once they start seeing them get a fever and getting confused and, you know, eating and drinking and peeing a lot, they're going to call and get that patient to the hospital. Okay, so when is a non-rebreather being used or when is a nasal cannula being used? So a good question, right? So again, you would have to be guided by the patient's condition, the patient's complaints, and pulse oximetry, right? So if somebody is saying they're a little short of breath and you put them on the pulse ox, a normal pulse oximetry is 94% or higher. So if they're saying that they're having some trouble breathing, but their pulse ox is 94% or higher, then I would just use a nasal cannula and I would start at about 2 liters per minute. And, you know, you can increase it as high as 6 liters per minute until they say their breathing's a little better. Remember, sometimes the sensation of feeling like you can't breathe is more psychological than physical. So by you saying, oh, I'm putting someone oxygen and they feel it blowing in their nose, you may just relieve the symptoms by just, it's called psychological first aid, by just, doing that to them. But if somebody's pulse ox is below 94%, okay, usually there we would start with a non-rebreather. And again, non-rebreathers typically 12 to 15 liters per minute, right? And, you can go, again, depending on the liter flow of your regulator and your oxygen tank, you may be able to go higher than 15, but most of the times, especially on the older regulators, 15 was the max flow, okay?
And you do humidified oxygens with a nasal cannula?
So we should, but do we use it in general? No. But where we absolutely should use it is anybody who's having a breathing problem, because once you're breathing a breathing problem, you're breathing faster, and when you breathe faster, you tend to dry yourself out. So anybody asthma or any kind of respiratory problem where they're breathing faster should be getting humidified oxygen, and kids should always be getting humidified oxygen because kids just dry out quicker, right? So,
Frank, I never saw somebody give humidified oxygen.
So you're absolutely right.
Why is that?
In Rockland County, because people are lazy. I got to be honest with you. It's
okay.
it's another step in what to do. But I don't know why. I mean, if you ever see a patient in the hospital, if you ever visited somebody in the hospital who's on oxygen, I would bet $100 and never even worry about getting my money back, saying that oxygen was hooked up to a humidifier on the wall and it was bubbling through some water. It's just, we get away with it because we say our transport times are short and we're not going to dry the patient out in the couple of minutes it takes us to get to the hospital. That's why we get away from it. It's not necessarily the right thing to do, but we get away with it. Okay. So, I have to tell you, like, I don't know, it was maybe four weeks ago. I had a patient, it could have been COVID. Maybe it wasn't COVID. I don't know, but they had a cold. And they were pretty dry. You could see mucus was dry around their nose and everything like that. So we're, the EMT says, should I put them on some oxygen? I said, absolutely. I said, but just make sure it's humidified oxygen. And the kid looked at me like I had 7 heads, and he goes, well, how do I do that? And I said, well, you got to get your humidifier out. He goes, well, where would that be? I said, well, it's your ambulance. I don't know where you keep them, but usually it's kept where the oxygen supplies are. So it just happened to turn out that they didn't have a humidifier. So, it was not something that we could do, but it would have been better for the patient, if we were giving them humidified oxygen. So of course, as soon as they got to the hospital, that's what the patient, got at the hospital. Okay. So somebody wrote, is a trauma patient with above 94% nasal cannula? No. Medical patients, we're talking. Trauma patients, okay, so legitimate, serious trauma patients always get 100% oxygen. Okay, so whoever wrote Isaac, very good. Okay, it's true that trauma patients always non-rebreather, 100% oxygen. Okay, so only when we're talking about, they use the term titrating oxygen. In other words, giving oxygen based on pulse oximetry or the patient's complaint. That's always a medical patient, never a trauma patient. Trauma patient, legitimate trauma patient, always gets 100% oxygen. Okay. So now let's talk about some other causes of altered mental status besides the diabetic problems. Okay. Okay, so sepsis, you've probably heard, right? Septic shock, sepsis. Well, this was one of the distributive shocks that we talked about when we covered shock, right? So sepsis is basically that somebody gets an infection that gets very serious very quickly and starts to spread through the bloodstream and go to the entire body. And that in the process of the body trying to fight the infection, okay, and also some of the substances given off by the infection cause the blood vessels to dilate. Okay, so in sepsis, they're not actually losing fluid. What's happening is it's a distributive shock so that the blood vessels start to vasodilate. And because they start getting bigger, the pressure drops, right? So that's what basically kills somebody who has sepsis. Now, sepsis is the condition that leads to septic shock. So not everybody who has sepsis, okay, will have septic shock if they're treated appropriately and quickly. And obviously the treatment for sepsis is usually antibiotics. So that nowadays, patients that come into the hospital are given what they call broad spectrum antibiotics, which means the big guns, the big heavy duty antibiotics right away. What used to happen was that they would draw what they call blood cultures, and they would try to see what the actual bacteria was and prescribe the least dangerous antibiotic for that condition. But if somebody's presenting like they're in early sepsis, there's no time to let the blood cultures come back because they take 24 to 48 hours to cook. And by then the patient will be dead. So this is again what they found out by, unfortunately, a lot of patients dying. So nowadays, if a patient, and I'll show you the classic signs and symptoms in a second, if a patient presents like sepsis, the treatment is pretty quickly to get them, once they draw blood, is to get them on, pretty powerful antibiotics. Okay. So again, what is sepsis? Sepsis is a body-wide infection that kind of overwhelms the immune system. Again, the immune system is the part of our body that protects us from things. Most of the times it does a good job. And then sometimes it overreacts. And we gave the example of anaphylaxis. This is an overreaction of the immune system. And also with COVID, we're finding now that everybody thought it was really like a pneumonia breathing type of problem, but it's actually an over-response of the immune system that's typically killing people most of the times. And that septic shock is the worst form of sepsis, where because of all the different poisons that are circulating in the bloodstream, there's massive vasodilation, okay, and it drops the patient's blood pressure. And once your blood pressure drops, your organs don't perfuse and they start to shut down, okay? And we said that sepsis is one of the forms of distributive shock. And if anybody remembers, there were a couple other types of distributive shocks. Technically, anaphylaxis is a form of distributive shock, neurogenic or spinal shock, right? And then the vasovagal was another form of the distributive shocks. They're all caused by not fluid loss, but by vasodilation, massive vasodilation, dropping the blood pressure. Okay, so what are the signs and symptoms of sepsis? So again, first of all, who gets sepsis? Well, any one of us can get septic. Okay, any one of us can get an infection and get septic. But again, statistically, who is it more common in? The very old, because their immune system is starting to break down, and the very young, because their immune system is not that strong yet. But anybody can get sepsis, right? I mean, it's possible, for anybody in the world to get sepsis, but again, most commonly very old, very young. Okay, so the first number one sign is an altered mental status. We're not talking about unconsciousness. We're just talking that they're confused. And in fact, in the elderly patient, the number one early sign that's often missed is confusion, right? People say, oh, they're old, that's why they're confused. But the number one most earliest sign of sepsis in a elderly patient is that they're not responding, they're not thinking clearly the way they were a couple days ago, right? It's a slow change, so sometimes it's missed, but they're not themselves. That's the most common thing I hear, with sepsis, they're not themselves. Okay. The second thing is there's some suspicion of infection. Okay, and sometimes that's hard to tell, right? Like if it's an early urinary tract infection, sometimes it's hard to know that, right? I mean, if they tell you they're peeing a lot and it burns and it's smelly, okay, yeah, then you could suspect a urinary tract infection. But if they're, we go there and say, well, you're saying the patient's a little confused. Okay, their skin feels a little warm. Are they having any problems urinating? No, they didn't say anything. When you say to the patient, are you having any problems urinating? You ask an old person something, usually they'll just say no. So it's a lot of times hard. The only way you're going to know somebody has a urinary tract infection is to do a urine culture, right? Have them urinate and have it looked at under a microscope. Again, we don't do that in the field, but that's the only way. Now, in an elderly female patient, the number one cause of sepsis, okay, is usually a urinary tract infection. A UTI is the abbreviation for a urinary tract infection, okay? Again, it's only more common. Men can get urinary tract infections, but just anatomically, the way we're built, it's more common for women to get it than men, okay? But that's always something to suspect. So if somebody says, my mother's not acting herself, she's a little confused, she doesn't want to eat, she seems to be breathing a little fast, her sound, when I feel her wrist, it sounds like her heart's pounding. That's all early signs of sepsis that sometimes get missed, okay? Now, they may have a fever, they may not have a fever. Even though it's an infection, right? It may be early, they haven't yet developed an infection, or sometimes, and you felt it yourself, that when you were sick, instead of feeling warm, you actually felt cold and you were shivering, right? So sometimes they have a fever, sometimes they don't. So they usually say temperature either higher than normal or lower than normal, okay? Their heart rate's increased. Now I wrote maybe masked. Masked means hidden. So people who their tachycardia, their fast heart rate are hidden are people who are on blood pressure medications called beta blockers. And we've mentioned this a few times before. You mentioned it with anaphylaxis. Beta blockers are blood pressure medications that lower blood pressure by slowing down the heart rate. So the heart rate itself is slowed down and the force of contraction is slowed down, right? So now somebody's going into sepsis, and the body would want to try to keep the blood pressure up by getting a little tachycardic, but because this patient's taking a beta blocker, they can't get tachycardic, right? It's stopping their heart from beating faster. So it's going to hide that tachycardia. So the only way you kind of put 2 and 2 together would be to look at their medicines and see, that they're on a beta blocker. Now, does anybody remember? I said one of the ways to tell beta blockers is at the ending, the last couple of letters of the name of the medicine. Do you remember what the letters were? LOL, AL, atenolol, propranolol, metoprolol, right? So they end in either LOL, OL, AL. All beta blockers basically end in those letters. So that would be a good little hint that they're actually a beta blocker medication. Now, obviously, if they're on a beta blocker, they're going to have more of a problem if they go into septic shock, because beta blockers are designed to keep blood pressure low. And if somebody's going into shock, you want the body to try to keep the blood pressure up. Okay, but it's just, in other words, they're probably on a beta blocker because they had chronic high blood pressure, which can't go untreated, just because there's a 1 in a million chance they're going to get septic. So, they're going to be on that medicine. It's just going to make it a little harder for that patient to survive their problem now. Okay. Again, an increased respiratory rate, because when you get septic, you get a little acidotic. And again, just like in diabetes, we said they get the Kussmaul respirations to try to blow off the extra acid, the extra CO2. They also get this increased respiratory rate to try to blow off their CO2 and keep their acidosis down. Their blood pressure initially will be fine, but if they move into the septic shock, will be low. Their blood sugar level tends to go high in sepsis. Okay, it is possible for it to go low, but most of the times it goes high. It would only go low if they stopped eating. Their capillary refill is delayed if they're going into septic shock, just like everybody would be. Okay.
Frank, the color will be also pale.
Pale. Yep. Definitely.
So what would determine that's not cardiac versus sugar? What's going to make the difference? What's that going to tell me if the skin color, temperature, everything is same symptom?
Well, first of all, cardiac patients, okay, for the most part, unless they're really having a bad heart problem, in other words, like they've been having this heart attack for hours, most of the time their skin, they may get a little sweaty, they may get, a little cold sweat and stuff like that because they're scared. Again, all this cold sweat comes from adrenaline. So if I scared you, if I hid behind, the closet door and jumped out and really scared you, you would get tachycardic and you would get cold, clammy skin, because again, when I scared you, you secreted adrenaline, because adrenaline's your emergency hormone. So, again, what's the cardiac patient probably going to be complaining about? Chest discomfort, right? Some kind of discomfort. What's the septic patient complaining about? Probably nothing. It's probably the family picking up on the fact that they're a little confused, they're breathing fast, right? Their heart's pounding. So it's probably not the actual septic patient complaining about anything. It's probably somebody else picking up on the actual signs and symptoms. So, it's hard. I mean, again, listening to me teach in class is not the way you learn. I mean, you have to have the basic information, but the way you become good EMTs is getting out there in the field. We're not taking care of patients on your own because you don't know what you're doing yet, but actually working with people who do know what they're doing and seeing patients that are sick and starting to expand your knowledge and say, okay, I remember Frank talking about this in class, and this is what this guy has, and so on and so on. And remember, once you finish and you pass your state exam and stuff, you can always call me up. I mean, people always call me up and say, I just had this patient and this is what they had and this is what I thought, but it turned out to be this. Why was that? And I'll explain it to you. Or if you had a good job, I just had a kid I taught when he was 16 to be a CFR, and then when he was 18 to be an EMT. He was in a yeshiva for kids that were not fitting into the typical yeshiva environment, right? So he's one of those kind of special yeshivas, and they decided to keep the kids interested. They sponsored an EMT class for these kids, and the kids loved it. Anyway, now the kid's married, has kids, lives in Lakewood. He really straightened himself out and everything. And he just called me up about a great, kid under a car, and and the great job they did. The kid was fine. Called me up to basically, just thank me, I guess, for teaching an EMT class. But this is 10 years, 15 years since he was in EMT class. So I mean, obviously he became a good EMT because when he got an EMT class, he worked with people who took the time to explain things and train things and everything like that to him. Okay, so it says, should the glucose be high? Usually in somebody who is septic, again, just like when we said the patient who is having diabetic ketoacidosis, the usual reason their body gets out of whack is because they have an infection. So yes, usually the infection, because that's what sepsis is, kind of throws the body's ability to control the sugar out of whack. And also because they're sick, they're not taking care of themselves the right way, right? So they're not taking their insulin when they're supposed to, and they're not checking their sugar. So usually, most of the times in sepsis, the blood sugar will actually start to climb. I mean, if they're really, really severely sick, not eating, and they're going into shocky components, it may be low. But the most common thing would be a high blood sugar in sepsis. Okay. So again, what do we do for these patients, right? So what do they need? They need antibiotics and fluid. We don't have either on a BLS level. So what are we going to do for them? Okay, we're definitely going to put them on oxygen. Okay, again, you'd be guided by, this is a medical patient, so you'd be guided by the amount of oxygen they need by their pulse oximetry. So, you know, if they're satting around 94, 95%, I put them on a nasal cannula, a liter or two. Okay, if they're below that, I put them on a non-rebreather. As far as warmth goes, that really depends on, you know, do they have a fever and are they burning up, or are they freezing cold? If they're freezing cold, then you would want to wrap them up and try to keep them warm. But if they're burning up with fever, you don't want to wrap them up, because if the fever goes too high, we'll see in a second, they could actually have a seizure from the temperature going too high. Okay, you don't need to cool them if they have a high fever. Okay, I mean, unless they're really, 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 you know, burning up. But you know, you definitely don't want to wrap them up if they have a high temperature. You may need to cover them just to get them from the house to the ambulance in very, very cold weather, because if you take somebody who's sweaty and has a fever out into the cold weather, they're going to start shivering. And remember, we just said shivering is a way that we actually raise temperature. So shivering would not, you know, be of any benefit to kind of keep their temperature down. Other than that, there's really not much else we could do. Okay. I would kind of if you really suspect, you know, this patient has all these signs and symptoms and you suspect sepsis, I would put that thought in the family's head just a little bit. Say, listen, you know, we can never be 100% certain in the field, but, you know, you may want to just mention to the hospital, could this possibly sepsis? Because the quicker the patient has that suspicion verbalized, the more likely the hospital is to do the things they need to do in a very quick manner. Most hospitals are all on board with this, because it's one of the things that the government looks at in grading hospitals now, is how quickly from the time a patient comes in that's septic, how quickly they get blood cultures drawn, how quickly they're put on antibiotics and stuff like that. So, you know, it's one of the golden standards, so to speak, of what the hospitals are graded on. So they're much better about it than they were years ago. But the only reason that it became kind of like a thing the government looked at is there were so many people getting very, very sick, and the government was spending more money on their care, right? That's the only thing the government looks at, is where are they spending money? And then whatever they're spending money on, they try to reduce it by making the hospitals treat those patients better. So, okay, so now we'll talk about seizures, okay? Well, actually, let me backtrack to this for a second, back to sepsis. Just remember, it could be the silliest of things that could cause a patient to get septic, right? I mean, it could be that your kid falls and gets a cut and just not lucky, right? Some kids get a cut, it gets a little red, and a couple of days later, they're fine. Other kids get a minor cut and they develop sepsis. So it's really, you know, as a problem, it's something that really requires, you know, constant monitoring, right? In other words, you don't know. What the long and short is that we all have bacteria on our skin. Every one of us, we all have bacteria on our skin. It plays a good role, okay? But when there's a break in the skin and it enters into your body, that's where the problem arises, okay? So again, some people get a cut, gets red, nothing happens, worse. Other people get very bad infections, gets into the bloodstream, gets septic. So, you know, just it really just comes down to somebody picking up on it. Okay. I mean, I don't know if I could show you on this computer, but I woke up with a pain in my shoulder, my left shoulder, and had no idea what it was, but I had this terrible pain. I thought I slept poorly and everything. I was making myself breakfast, and one of my sons comes out, and I said, "Do me a favor, can you look at my shoulder? I just have this pain, it's throbbing and everything." So he looks at it and he says, "You know, you have a huge pimple on your shoulder." And I said, "Really?" I said, "Take a picture of it." So he takes a picture of it on his phone. He shows it to me. I'm like, "Oh," I said, "That's like, looks like a hair hair follicle that got infected. There was a big like pus head on it and everything like that. So I said, you need to rupture that. You need to break it, and I got to drain it. So whatever, do all that. Probably should have went to my wife's office, got antibiotics and everything, but it was a busy day. I leave. That night, I started with a fever. I started shivering and everything like that. I got a very, very bad infection. I was probably borderline septic. I wound up being on 3 different antibiotics for like a week, and it was just basically an ingrown hair, but it wasn't necessarily treated properly, right? I should have been on antibiotics right away. I was 2 days delayed getting on antibiotics and stuff like that. So it's possible to happen to, anyone, and again, the younger you are and the older you are, the more susceptible you are to having it. So, I guess what I'm trying to say is any story could be a legitimate story, right? It could be the silliest of things, that it could happen. So, okay. So, we talked about this. Okay. So now we're going to do seizures. So on the test, okay, sometimes instead of using the word seizure, they use the word convulsions. Let me see if I could find that. Okay, well, this is convulsant, but convulsions, I'll get back to the beginning in a second. Well, convulsive, but convulsions, S-I-O-S-I-O-N. So they use the word convulsions instead of the word seizure. Okay, so I just wanted to point that out. Well, look, when we look at questions, we'll go over it and stuff like that, but just to realize that. So what a seizure is showing that the brain's not controlling the body, right? So the brain is basically, the master computer of the body. When it's not controlling the body, and we'll talk about all the different reasons why it's not controlling the body, the muscles all start to shake, right? In other words, it's not controlling the different muscles of the body. So that's all a seizure is. Some people have seizures because they have a disease called epilepsy, okay, where they're prone to seizures. Not everybody's 100% certain why epilepsy occurs and stuff like that, but people have seizures for a lot of different reasons. Hypoxia, high temperatures, so somebody could have sepsis and have a fever, and then actually the fever climbs so high they could actually have sepsis. You've heard in children, right? Children whose temperatures climb very quickly, okay, can have what they call a febrile seizure, which is a seizure. A febrile means fever, so it's a seizure caused by a rapid increase in the temperature. Okay, in other words, the body didn't have time to get used to the temperature and it climbed too quickly and stuff like that. So there's 2 different types of seizures. There's basically a partial seizure that only affects a certain part of the body, like one arm, one leg, or anything like that. Okay, patient's usually conscious. Okay, there's even seizures where there's no shaking that occurs and the patient just basically zones out. So in other words, you're looking at them, you're talking to them, they're looking at you, but they're not there, right? There's no response to them. So the other names for partial seizures are focal. Focal means like when you remember you had your focused assessment in patient assessment, somebody broke their arm and you were only going to take care of looking at their arm because that's the only problem they had. So focal means just one part of the body, or sometimes it's called petite mal. Petite means small, and mal is French for like shaking. So petite mal, okay, versus a grand mal for a generalized seizure where the whole body is shaking, okay. Or we also call those major seizures tonic-clonic, because what happens is the patient gets tight. That's the tonic stage. Then they go into the clonic or clown-like shaking stage. So there's different types of seizures. On a 911, we typically only respond to the real big seizures, the grand mal seizures and stuff like that. Okay. So when a patient has a tonic-clonic or grand mal, the big seizure, they go through some classic stages. So this we're not usually there for. The aura is that a lot of seizure patients right before they have their seizure have what they call a state of heightened awareness. Okay, so it's fancy to say that the seizure patient, okay, right before they actually have the seizure, will see things, hear things, smell things that nobody else sees, hears, smells. So in other words, that their brain is someplace else at that second. Okay, sometimes they remember it, sometimes they don't remember it. Okay. It lasts for a second or two, then the patient becomes unconscious, right? So all of a sudden, they zone out. You don't know that they're hearing or seeing something. They lose consciousness, and then they go into the tonic stage where their body gets very tight. They're like rigid for a couple of seconds, right? Up to 30 seconds or so. And then they go into the clonic stage where the body starts shaking around, okay? Now, how long the body shakes for depends. it always seems like it's a very, very long period of time, okay, especially to bystanders. But most of the times it's less than a minute. But even when you're there with the patient, it seems like a very, very long period of time. Okay, but again, it's usually, less than a minute. Okay, but it can go on. We'll talk about very serious seizures. After the seizure stops, they go into what's called the postictal phase. And the postictal phase is basically a sleep-like stage where they're unconscious but starting to come around. And it typically takes about 5 to 20 minutes for them to completely wake up, maybe even as much as a half hour. Okay. So again, most of the times we probably get there after the tonic-clonic, because that's what made them call the ambulance, right? Made the bystanders or the family call the ambulance. And we usually get there in a postictal stage. Okay, now how do we know that it's postictal stage after a seizure versus there's other reason why they're unconscious is because the family tells us they have a seizure history, okay, and that they went through and were shaking and everything like that. So that's kind of how we know that we're dealing with a seizure. Could it be the first manifestation of somebody having a seizure problem? Yes. But again, if they're describing, okay, the kind of shaking and the tightness and all that stuff, we can kind of suspect that it's a seizure. Okay, so again, some seizures have that aura. We're never going to be there for it unless actually, I don't know, the family calls you and says, the patient kind of zoned out. We can't get them to respond. And, you're right around the corner, you show up and, the patient's kind of like looking at you, but not really responding to you. It could be that they're actually in that aura-like stage. I've never seen that. But, I have heard patients describe that right before they had the seizure, they heard things or they smelled things or they saw things and stuff like that. Okay, so the number one cause of seizures is that a patient has a condition called epilepsy, which makes them prone to seizures. This could be secondary to having head trauma, previous head trauma. This could be secondary to drug or alcohol abuse, or this could be just that that's the way they were born, right? The number one reason why we go to seizure calls is that the patient has a history of epilepsy and they stop taking their medications. Okay, so patients who have a history of epilepsy are put on what they call anticonvulsive medications, which stop them from having the seizure. The patients don't like the way it makes them feel, okay, don't like the cost of them. So what will happen is they'll experiment with starting to cut back on taking it every day, right? So they've been taking it for 6 months, they haven't had a seizure, and they say, well, let me skip a day and see what happens. So they skip Tuesday, and Tuesday goes by, they don't have a seizure. So they say, okay, let me skip a second day. Okay, and now what's happening is that by skipping one day, they still have an adequate level of the medication in their bloodstream, so nothing happens. But when they start skipping multiple days, the level of the medication in their bloodstream starts to drop, and usually after the second day, they will have a seizure. Okay, and we get there, and they start waking up. They're in that postictal stage. They start waking up, and we say to them, what happened? I don't know. Are you, do you have epilepsy? Yes. Are you taking medications? Yes. Are you taking your medications like you're supposed to? Well, no, I kind of ran out of them, or they usually don't tell you they stopped taking them. They say they ran out of them. So you know what the cause of their seizure was, okay? That they didn't take their medications like they're supposed to, okay? Now, a patient who is a diabetic, who's an epileptic and has seizure problems and is taking their medicine like they're supposed to, but is drinking alcohol, can also have a seizure. So I used to have a guy that lived on my corner that, every Shabbos, he would indulge in shul in some alcohol. And pretty much during the Suda, coming after we came home from shul, he would have a seizure. I'd say probably once a month. And the kids would come running around the corner and get me and stuff like that. And, the cause of his seizure, because he was compliant with taking his medicines, he took his medicines like he was supposed to. The problem with having his seizure was that, 1 glass of alcohol was fine, but 3 glasses of alcohol would trigger a seizure in him. So again, the first one we described was that the patient's not taking their medicines. That's why they had their seizure. The second one is they're taking their medications, but they're drinking alcohol. So that will usually trigger a seizure. Now, what are some other reasons people have seizures other than epilepsy? So hypoxia, right? Anytime the brain is not getting what it needs, that can cause a seizure. So hypoxia is definitely one of the reasons why people have seizures, okay? The earliest manifestation of somebody having a brain tumor, right? You don't know if you have a brain tumor, right? So the earliest symptom is headache. But again, do we immediately think we have a brain tumor because we're getting headaches? No. So usually the way somebody gets diagnosed with having a brain tumor is they get a CAT scan because they had a seizure that they don't have any history of seizures. They have a seizure and the ambulance brings them to the hospital with the story of that they had a seizure, don't have a history of seizures, and they do a CAT scan and they find a brain tumor. So that's the number one. Epilepsy is the name of a disease that they give to people that have repeated seizures. They don't actually know what's causing it, but that's what epilepsy is. Somebody just asked, what is epilepsy? Okay. Okay, strokes can cause seizures, again, because in a stroke, the brain is not getting what it needs. Somebody who has head trauma can have a seizure because the brain is damaged. Low blood sugars can cause seizures. Fever, okay? So in kids, it's called a febrile seizure. It does not mean that they're doomed to be an epileptic, although there's a slight increase in epilepsy in kids who have febrile seizures. But in a febrile seizure, it is a child who has a fever because they have it's a child who has a seizure because their temperature is rising in response to a cold, into an illness, but it's rising too rapidly, okay? Other reasons with temperature would be somebody who has an emergency called heat stroke, where they're in a hot, moist, humid environment and their body's not cooling, okay? And the term for high temperature is just called hyperthermia, right? We've had hyperoxia, we've had hyperglycemia. So hyper just means a lot of. Hyperthermia means high temperature, okay? Okay, again, brain infections like meningitis and encephalitis can cause seizures. Infections, okay, that enter into the bloodstream but go to the brain, okay? Idiopathic seizures mean that they don't know why they're having seizures. So anytime you see the term idiopathic, it just means that, yes, we know they have a problem. We have no idea why they're having it, okay? Hydrocephalus is a problem where the cerebral spinal fluid that bathes the brain and the spinal cord is not draining off, is being produced too much of it and it's not draining off. So the head starts to swell, okay, and puts great pressure. These kids get shunts, get tubes that drain the extra cerebral spinal fluid down into their esophagus and into their stomach to get rid of it. If the shunt gets blocked, then they'll get terrible headaches and they can have seizures. These are kids, again, that are probably not fully functioning because they already have this problem and stuff like that. But the number one cause is a blocked shunt. We cannot unblock the shunt. The shunt is just a drain, draining the extra cerebral spinal fluid away. Remember, we all are producing cerebral spinal fluid right now. That's what bathes our brain and our spinal column to keep it moist and keep it perfused. But if you have too much of it, okay, then there's a problem. And once they have that problem with too much of it, they put a shunt in to drain it down, from the brain down into the esophagus. When it rises over a certain level, if that shunt becomes blocked, then the pressure builds up and they have a seizure, okay? When we do about obstetrics, childbirth, we'll talk about seizures in pregnancy, okay? So, I mean, any of you may have had, your wives may have had like their blood pressure starting to climb during pregnancy and stuff like that. They're very concerned of seizures when that happens, okay? And again, if the temperature goes too high, whether it be from environmental temperature, like being in a hot, humid environment, okay, or just because of fever, if the brain gets too hot, you can have a seizure. So the long and short of it is the brain has to be having the right amount of oxygen, right amount of sugar, okay, and in the right environment to work properly. If it's not working properly, you can have a seizure. If the brain is traumatized, you can have a seizure. So anytime the brain is not working perfectly, it's going to show that by not controlling the muscles of the body, and the person's going to have a seizure. So what do we ask them? So what was the person doing before the seizure started? Okay. What did the person do during the seizure? In other words, if they just zoned out and there was no shaking, then it's not a grand mal seizure. It's not a major seizure, right? How long did it last? Now, remember, everybody's going to add multiple minutes to it. It's like a seizure of 10 seconds is going to be a minute. There's no doubt about it. Just we would do it ourselves. It just seems when there's an emergency that everything takes much longer and stuff like that. And then what did the person do after the seizure? Again, you're usually there at that point, but they usually go into that sleep-like stage, okay? We're very concerned if they tell us that they had a seizure, okay, and then went into that sleep-like stage, and before we got there, then had a second seizure. So in other words, they're having repeat seizures without ever waking up, and we'll talk about that in a second. Okay, so what do we do for a patient who's seizing? So we don't hold them down, we just kind of protect them. In other words, holding them down would just be more likely for them to injure themselves. We don't put anything in their mouth because they can bite down and break it, or they could break a tooth or anything like that. So all we really want to do is get them onto the ground so they can't fall. If we have them on the stretcher and they're strapped, that's fine. Okay, but we don't you know, hold them down, so to speak, and stuff like that. Okay. If they're laying on the ground, again, you can put some padding under their head so their head's not smacking on the ground, or have somebody cradle their head and stuff like that. And, you know, like I said, the seizure will stop. Okay. It's the very rare seizure that continues and continues and continues. Most seizures last a minute, at most, maybe 2 minutes, and then they stop. Okay. But again, nothing in the mouth, and you don't hold the patient down. Okay, after the seizure, when they're in that postictal state, this is the word convulsions I was talking about. That's how they're going to describe a seizure on the state exam for some reason. Okay, again, they're going to be unconscious, snoring respirations. You don't really have to insert an oral airway because they would just gag on it but if they're having a seizure and not waking up, you may consider a nasal airway. Okay, you can put their patient on the side. Okay, unless you think there's a possibility of spinal injury, which again is probably non-existent. Okay, if they're cyanotic, it's showing they're not breathing well. So again, as best you can, get some air into them, get some oxygen into them. If they're breathing enough times a minute and deep enough, a non-rebreather is fine. If not, you may need to try to bag them, although it's very, very hard to bag a patient who's seizing. Okay, so again, oxygen. Okay, if they've had any trauma, in other words, when they had the seizure, did they fall and cut themselves or hurt themselves? Then you would have to manage that and, you know, transport to the hospital. Now, status epilepticus is the condition where it's a dangerous seizure. They're having repeated seizures without ever waking up. So they had a seizure, they went into that postictal state where they were sleeping, okay, and then they had another seizure, and then again another seizure, and they're never ever waking up, or it's they have a seizure lasting more than 10 minutes, okay. I've never seen a seizure last more than 10 minutes where they're actually doing the shaking and stuff like that. I've seen seizures where the patient's arm's just shaking, not their whole body. Okay, but I've never had a seizure where it's lasted more than 10 minutes. I have had people who are having repeated seizures without waking up. So they'll have a seizure, they'll go into the postictal state for a minute or two, and then they'll have another seizure, and so on and so on. I actually had one very recently. Okay. So the problem with that is that they're never going to be breathing properly, right? When a patient's seizing, they're really not breathing well, right? Because all their muscles are tight and shaking and everything like that. So they're going to get very hypoxic. If they're having repeated seizures and never stopping, their oxygen level is going to fall dangerously low. Okay. Even putting them on oxygen is not going to help because while they're seizing, they're not breathing well. So it's not going to hurt them to put them on oxygen, but it's not really going to help them. And again, trying to ventilate somebody with the bag valve mask when they're seizing, you have to try, but it's really kind of next to impossible. It's very, very hard to do it. Okay. So it says somebody asks, why does someone with epilepsy need to be transferred? What is there to do? So it comes down to if somebody has a history of epilepsy, has one seizure and wakes up and they're fine to the point where they're conscious, alert, and oriented and don't want to go to the hospital, then you're right. There's not anything that's going to be really done in the hospital for that patient. But if they're having repeated seizures and the seizure is not stopping, then they obviously need to go to the hospital to get medication to stop the seizure. Or if they're telling you that they've been having seizures over a couple of days now, it means their medication needs to be adjusted. So they're only going to get their medication adjusted by getting into the hospital, and the hospital then calling their neurologist and making a discussion on how to adjust it. So, you know, the problem is we leave the patient in the house, okay, and now they have another seizure, they fall and hurt themselves, okay, or something worse happens. And you know, we have to explain, you know, why did we not transport that patient to the hospital the first time we were there? So I'm not saying that every patient who has a seizure gets transported to the hospital, okay? But if you can, remember, what's our purpose? Our purpose is to get patients into the healthcare system, okay? I understand, you know, there are families, right, parents who have kids who have seizures repeatedly, and there's no reason in the world they want that kid to go to the hospital because it's just going to be an expense. And again, nothing's going to really happen at the hospital because the kid has a seizure problem. A lot of those situations, the parents actually have medication themselves to treat the kid and stop the seizure. And they don't even 90% of the time even call the ambulance unless something goes wrong. So I understand both sides of it. Again, we're more concerned on our side of it, which is, you know, we don't want to be accused of not treating a patient the right way. But again, if it's a minor and the parents have guardianship over the child, then they can technically sign an RMA. You just have to point out the risks of not transporting that kid. And again, if it's a seizure patient who wakes up and is conscious, alert, and oriented and wants to stay home, but they're able to understand what's going on, you know, technically they would be entitled to refuse care. Okay, I wouldn't encourage it to happen, but you know, technically they would be allowed to refuse care. Okay, so again, status epilepticus is the worst type of seizure, and that's where they just keep on seizing, right? That's the problem. They don't have a break in their seizures. It just keeps on happening and happening and happening. Okay. Okay, so not all seizures are generalized tonic-clonic seizures, right? That's the worst one. That's usually what we get called to and stuff like that. Okay, but there are people who have those partial or petit mal focal seizures, and that's basically that they either, one, it's called an absence, like you're absent from school, an absence seizure, where you're there, there's no shaking, but you're not responding, okay? Or they have what's called a focal seizure, a partial seizure, where maybe just one arm shakes, one leg shakes, it doesn't progress onto the whole body, okay? Again, do those patients need to go to the hospital? If that's a known problem and it's stopped and the patient doesn't want to go, or the guardian doesn't want the patient to go, and you feel comfortable with it and they sign an RMA, I guess you technically can leave that patient in the hospital. Okay, so again, the generalized seizures are called the tonic-clonic seizures, the whole body shaking. That's the typical seizure that we get called to. You can have the minor seizures, so the absence seizure, okay, just, basically they are there, but they're not responding, okay? So there's no shaking or anything like that. It can go on for, a minute or so, and then all of a sudden they wake up and, there's as if nothing happened, okay? A lot of times it's totally unnoticed by bystanders. It's only the family that picks up on it and stuff like that. It would be kind of like, you're sitting around a table with a whole bunch of people and one guy's not talking. And then 1 minute later he starts talking and you don't notice that for a whole minute he wasn't talking. It could be just that he was bored, or it could be this, in the history of a patient who has absent seizures, they actually had a seizure. Okay, so any questions on the seizures? Remember, the pediatric seizure is called the febrile seizure. Very, very scary for the family, okay? A lot of times the kid will turn blue because they're seizing and they're not breathing well. But usually by the time we get there, the seizure has stopped, okay? Because it's caused by a high temperature, loosening clothing, okay? Trying to cool them down a little bit, maybe, taking a washcloth with some, lukewarm water, not cold water, but some lukewarm water, and just patting them down a little bit. Will help bring their temperature down and stop them from having a second seizure. I've never had families say they didn't want to have the kid go to the hospital, because it's not something that the family, thinks is normal. But maybe if the kid has a history of having a lot of febrile seizures and the family's kind of used to it, they may be a little indifferent to the child being transported to the hospital and stuff like that. Again, you can't force anything, but probably it would be a good idea for that kid to go and get evaluated. Okay. So again, somebody asked, I guess they're talking about the absent seizure. If nothing is shaking, how do you know it's a seizure? So in an absent seizure, it's basically that they're going to describe to you, again, most of the times the family knows the patient has a seizure history, right? People know the patient has a seizure history, that they have these absent seizures, but it's basically going to be described to you that the patient did not respond, never lost consciousness, never was shaking, but was not responding for a period of time, typically less than a minute. That's what an absent seizure is. Sometimes you'll see this in like a group home setting, where they'll just say, oh, they just zone out and then they come back, but now they're not coming back. So that's why we called you. Okay. So that's kind of what you're facing. And there's nothing really to do. I mean, there's no emergency, right? There's nothing to treat or anything like that. It's just basically protecting the patient from, God forbid, if they have a full seizure now, falling and hurting themselves. Okay, so let's do stroke. And I know it's getting late. What time is it? 10:26. Okay, let's try to get through stroke because I don't want to kind of fall behind, and then we'll call it a night. Okay, so a stroke is not really the term we use anymore. Well, really what they call now a stroke is called a brain attack. The first term for a stroke was cerebrovascular attack. So cerebral means brain, vascular means blood vessel accident, and we abbreviate that as CVA. Nowadays, they like the term brain attack. On a state exam, they call it a non-traumatic brain injury. In other words, there's no trauma causing it. But there's a couple different reasons. It's a brain being deprived of blood because either the blood vessel is blocked or the blood vessel bursts. Just like a heart attack was caused the heart not getting blood because either the blood vessel was blocked or the blood vessel bursts, it's the same thing with a stroke. And just like in a heart attack, 95% of the time it's the blocked blood vessel, not the burst one. It's the same thing like a stroke. Most strokes are caused by a blockage, not a rupture of a blood vessel. Okay. Now we know, just like the heart attack, that when a blood vessel is blocked, the area past the blockage does not get the oxygenated blood it needs. So it's going to die, right? Because the area beyond the blockage is not getting the oxygen, the sugar it needs to stay alive, okay? So there's two types of strokes. There's what we call an embolic. Sometimes it's called ischemic. Ischemia means that tissue is not getting blood. Embolic is a dry stroke, means there's no bleeding, and it's a blockage of the artery supplying part of the brain with blood, right? So now how big of a stroke it is depends on which blood vessel is blocked, what part of the brain, what does that part of the, just like a heart attack. In other words, how much of the brain is being deprived of blood, okay? Then we have the hemorrhagic, the bleeding, right? Hemorrhage is bleeding, which is called the wet stroke, okay? And that's caused by a ruptured blood vessel, typically from an aneurysm. The other night we talked about an aortic aneurysm. This would be an aneurysm of cerebral blood vessel in the brain, okay? Again, 95% of the time, it's an embolic, ischemic, dry stroke. Very rarely is it a hemorrhagic or wet stroke, okay? So embolic or ischemic stroke, both, it's just the same problem, just different terminology. This is the dry stroke. It's a blockage of an artery bringing blood up to the brain. It's the most common type of stroke, okay? And it's typically caused by a clot that travels from either the heart, because the patient's in atrial fibrillation, or from a carotid artery. Remember, you have two carotid arteries on either side of your neck, and they could have plaque or fat building up inside of them that breaks loose and goes up to the brain, because your carotid arteries are pumping blood up to the brain. Hemorrhagic strokes or wet strokes or bleeding caused by a ruptured blood vessel. They can be from an aneurysm, which is a dilated or weakened artery, okay? The typical cause of aneurysms is high blood pressures. There's a special type of problem that could develop, which is called an AVM, or atrial venous malformation. They're not going to ask you about that on a test, but I'm just going to show you what that is, okay? An AV malformation is that an artery never goes directly into a vein, right? What's between an artery and a vein? Capillaries, okay? So why were we built that way? Because the pressure in an artery is very, very high, okay? If it were to go directly into a vein, it would actually, the vein couldn't handle it. An artery has 3 walls to it, a vein only has 1 wall. So if an artery hooked up directly to a vein, it would actually overpressurize the vein and give it an aneurysm. So to make that not happen, between arteries and veins are the capillaries. And as the blood goes into the capillaries, right, it drops the blood pressure, it lowers the pressure. And by the time it travels out of the capillary, it's very low pressure and the vein can handle it. Some of us are born with a defect where some of our blood vessels connect directly. Some of our arteries connect directly to some of our veins. Sometimes you see that as blood spots or like birth spots on the skin, okay? But again, it could be inside your body in dangerous areas where that happens. There's no way of knowing, okay? The only way you could pick this up is having a CT angiogram done, of your entire body and seeing if there's any areas where they show up. So that's not done routinely. So there's no way of knowing if this occurs in your body. This is something that's typically found on autopsy when somebody dies of a hemorrhagic stroke, okay? And then there's one type of hemorrhagic stroke called a subarachnoid hemorrhage. Now, all it means is, remember, there's different linings to the brain. There's the dura mater, the pia mater, and the arachnoid membrane. The arachnoid membrane is the very clear, thin layer right on the brain itself. So subarachnoid means it's under that layer, right on top of the brain. And the classic presentation is they will call you to the house. They'll be sitting in a darkened room because the light bothers their eyes, and they'll be saying they have the worst headache of their lives. They feel like their head's going to explode, and it's called a thunderclap headache, okay? Now, again, migraines can present similarly. So if people have a history of migraines, that's the problem. How do you tell the difference? And there's no real way of telling it, except that if they have a history of migraines, we assume that it's a migraine and not a subarachnoid hemorrhage, okay? If somebody has no history of migraines and they have the worst headache of their lives, then we kind of assume it's that subarachnoid hemorrhage. And I know you've heard in the various different communities, you always hear these stories of these young women or even middle-aged women or older women, but no history, and basically have a history of a headache for a couple of days, and then all of a sudden they're dead. So that's the typical presentation of a subarachnoid hemorrhage, okay? It's an aneurysm that develops and ruptures and causes a massive bleed. The headache is right before the worst part of the headache is right before the actual rupture. Okay, an aneurysm, yes, it's a blood vessel that dilates. I'm going to show you a picture of it in a second. Okay, again, in other words, it's an artery that's under great pressure and it kind of like looks like the tire that gets a bulge in it. And if it ruptures, the patient dies. Okay, so let's look at the different types. So dry strokes, we said, the ischemic strokes, right? There's no bleeding, okay? It's either caused by what they call a thrombus or emboli. So you don't need to know that the other name for a dry stroke sometimes is an embolic stroke, but I just wanted to explain to you the two different ways that it could happen, okay? So a thrombus means that there's fat that developed in an artery, okay? And sometimes a piece of it could break loose, just like kind of in the heart attack we were talking about. So in your carotid arteries, you could have fat, just like in your coronary arteries in your heart, right? This is in your neck. You could have a little piece of fat developing, okay? Again, because we don't eat well. If it breaks loose, it will float up into the brain and cause a stroke. That's what a thrombotic is. Embolic means that it's coming from somewhere else. Something broke loose, okay? A piece of fat broke loose from someplace else in the body, okay? And traveled up into the brain. This is that there was fat in this artery, okay? And it traveled up. This is that it's coming typically from the heart. The number one reason why people have embolic strokes, which is the most common dry stroke, is they have what's called atrial fibrillation. Atrial fibrillation means the upper chambers of the heart, instead of contracting normally, are quivering and shaking. And because they're not contracting normally, blood clots up in there, okay? And now all of a sudden, for one contraction, they contract normally, and a blood clot shoots out, okay? It goes up into the aorta and then travels up to the brain. I'll show you that in a second. And then the wet stroke, the bleeding, is typically caused by an aneurysm or a burst blood vessel, okay, in the brain. Very rare, okay, but devastating. So now let's look at the dry strokes, okay? So we said that one is embolic from the left ventricle caused by AFib. Okay, so what are they showing you here? They're showing you that the patient has atrial fibrillation. The upper chambers of the heart, instead of contracting and pumping blood, are shaking. Okay, you're still alive because your ventricles are working fine, but because they're not completely emptying, because they're shaking and not contracting, you could develop a clot. If it's your left ventricle, it's going to pump up into the aorta. So you see the aorta right here. And we said off of the aorta is 3 big blood vessels that bring blood to your brain and to your upper part of your body and your arms, your upper arms. Okay, I mean, not your upper arms, your arms and your upper part of your body and your brain. If it comes up, the first branch on the arch of the aorta, okay, is what's called your common carotid artery. And it comes up, okay, up into your neck, up into your brain, and you have a stroke. So that's a stroke caused by atrial fibrillation. Okay. Again, they're not going to get into this level on the test, but just understand that an embolic stroke is a dry stroke caused by a blood clot. Okay. Now, another type of dry stroke is that people can have actual plaque developing in their neck, okay, just because of poor diet and stuff like that, and it breaks loose and travels up to the brain. That would be called a thrombotic stroke. Again, they're not going to ask you this level on the brain, but I just wanted to explain the differences on it. So you see basically that the clot comes up and it blocks blood flow up to the brain, or it actually makes it up into the brain and blocks blood flow further, right? So those are the two types of dry strokes. Okay. Again, on the wet strokes, those are typically in aneurysms. So this is a normal blood vessel. This is a blood vessel that develops that weakened aneurysm in it. And if it bursts, okay, then they have what they call the wet stroke. Okay. So it'd just be like they have almost like a brain trauma, right? They're bleeding just like they were hit in the head when David did the class on the different types of bleeds, but this is non-traumatic. This is just overpressuration of it, or it's that AV malformation. So you hear they say weakened artery. So they're probably saying that there's an AV malformation and that's what's rupturing there. Now, here's the deal. The first test that any stroke patient gets when they get to the hospital is what they call a non-contrast head CT, head CAT scan, because they have to know whether it's a dry stroke or a wet stroke. If it's a dry stroke, okay, where there's no bleeding, then they could do a couple of things for that patient, depending on where it is the clot is in. They know from the CAT scan where the clot is. They could give them what they call thrombolytic medications to dissolve clots, okay, and try to reopen that blocked artery, or they could actually bring a catheter up to the artery and try to pull it out. It depends on how deep up in the brain it is. If it's very deep in the brain, then they can't pull it out. But if it's in one of the larger blood vessels at the start to the brain, they could actually try to go up and pull it out, okay? So there's something to be done for somebody who's having a dry stroke. an embolic stroke, right? Ischemic stroke, that's all the different names for it. But the problem with the hemorrhagic stroke is that it's a burst blood vessel that's arterial, right? It's a burst artery bleeding into their brain. So the chances of actually that patient surviving are pretty minimal. If they could catch it, like the patient goes into the hospital with that terrible headache, but it didn't rupture yet, they do a CAT scan and they can see it, okay, then they could do stuff for it. They could, if they can get to it before it ruptures, they could kind of deprive the blood from getting into it. What they could basically do is seal off and not allow any blood to get into the aneurysm, okay, and you know, treat it before it ruptures. But if it ruptures already, there's not really much you could do for that patient, okay. But when you bring a stroke patient into the hospital, sometimes they'll actually ask you not to stop in the emergency room, to go right to CAT scan. All the emergency rooms have a CAT scan right in the emergency room. They'll ask you to go right to the CAT scan because there's nothing they could do for that patient until they get the CAT scan and see whether it's a dry stroke or a wet stroke, okay. This is showing you the AV malformation, atriovenous malformation. So basically what happens is that right here you have an artery and here you have a vein. There should be a capillary bed in between it, but they just have this hodgepodge of blood vessels, okay? So what's happening is the high pressure from the arteries are going into these veins, okay? And these veins can't handle it and they could rupture. So that's what's basically happening when somebody has an AV malformation. This is actually a CAT scan of somebody who died, okay, of a hemorrhagic stroke caused by an AV malformation. So you could actually see that this whole section of the brain was just a mass of blood vessels, okay? And obviously in the case of what this guy, probably they ruptured, and that's why we're looking at his, you know, his CAT scan of his brain, okay? So again, don't worry about it. Most people don't have them, but it's, you know, it's a common reason why people have wet strokes, but wet strokes are not common. So again, it's not something that you really have to worry about. Now, what do you have to know about the test? Okay, so on the test, you have to know that there is what they call a ischemic or dry stroke, embolic stroke, and that means there's no bleeding, and you have to know that there's a wet stroke or hemorrhagic stroke where there's an aneurysm that ruptures. Okay. Now, the other thing they're going to ask about is the signs and symptoms. So typically, people who have strokes have what they call a one-sided deficit. That on the side opposite the stroke, the side of the brain, the side opposite of the part of the brain that's damaged, will be very weak and the patient will not be able to move, okay? So they're not going to have that both arms don't move. They're going to have that one arm doesn't move. They're not going to have that both sides of their face don't work. They're going to have that when you ask them to smile, because that's one of the signs we look for, that they have one side that droops. So one side works and the other side droops down, okay? When it's a bleed, okay, they may have, just like the head trauma patient, they may have a pupil that doesn't respond to light and gets very big, like fixed and dilated pupil, but that's not very common in embolic stroke. That's more the hemorrhagic stroke. They're going to have difficulty in speaking, difficulty in swallowing, okay, in both types of strokes. But again, embolic strokes are usually, hemorrhagic strokes are so quick to kill that we don't really ever really, those patients are unconscious by the time we get there. There's not really much in the assessment. It's the dry stroke that we can really assess. Okay, the headache is most common in the wet stroke, but again, they're those patients typically, you know, if it ruptures, they're going to be unconscious. So there's not much that we can really, you know, do in those situations. Okay, so what are some other signs of strokes? You know, especially the dry stroke: confusion, dizziness, weakness on the body, difficulty in walking. They may lose control of their bowels or bladder. In other words, they may go to the bathroom. They may complain of visual problems. You may find their blood pressure very high, although that's more common in the hemorrhagic stroke, the wet stroke, right? That's what's going to cause the aneurysm. When it gets real bad, they may have trouble breathing. They may have snoring respirations. Okay. Again, on the wet stroke, when their blood pressure starts to rise, they may have that nausea and vomiting, just like every time blood pressure gets high. Worst case, seizures, right? Unequal pupils, again, with the bleed. Headaches, again, more common with the bleeding type of stroke. Loss of vision in one eye is a specific type of stroke that's depriving blood to one eye. Okay, it's called a retinal artery occlusion. So you have somebody who has sudden loss of vision in one eye. That's usually what they call a retinal artery occlusion, the artery that brings blood to the eye. So it's not a brain per se, like the entire brain. It's just actually depriving blood to, you know, one of the eyes. I mean, still very serious. The person could be blind in one eye, but it's not like the whole brain is being involved, okay? And then unconsciousness is not very common in the dry stroke, the embolic stroke, but it is very common, obviously, in a hemorrhagic stroke where it actually ruptures and bleeding and stuff like that. Now, speaking to the embolic or dry stroke patient who's conscious but cannot talk back to you, right? So this is a difficult thing. In other words, they can hear you fine. They just cannot speak clearly. So you have to be very, very careful on what you say, and also to them, but also to the family. Okay, so because they understand everything that's happening. Hearing is actually one of the last senses that fails somebody as they're becoming unconscious. And I'll give you one little war story before we finish. I had a patient who had a low blood sugar, was unconscious. The guy was probably, I don't know, 300 pounds, huge, all muscle, all tattoos, you know, not looking like a real kind of citizen kind of guy, looking more like a criminal, unconscious in an apartment that was filthy, laying on the floor, and he was a known diabetic, not taking care of himself, unconscious. And he had a wife or girlfriend or whatever who was basically screaming, he should die, he's a piece of garbage, he hits me. The whole time the guy's laying on the ground, don't save him, and all this stuff. Anyway, so we start the IV, we give him some sugar, and he starts waking up. And the first thing he said is he turned to her and said, "You bitch, I heard everything you said." So the cop said to her, "Pack your bag, okay, and you need to leave the house now because we cannot leave you home with this guy because he's going to kill you because he heard everything you said." So always remember that hearing is the last sense that leaves someone. So when you're treating these stroke patients, you can talk to them. You could say, "I know you hear me and I know you can't speak to me, but I want you to know we're doing everything we can to help you. We're going to get you to hospital. And there's a lot of things that they can do for you, okay, to hopefully reverse what's happening, you know, and make you better." So, you know, you can give them some psychological first aid, encouragement, and stuff like that. I wouldn't turn to the wife in their presence and say, you know, it looks like he had a massive stroke, you know, and stuff like that, because that's not our job, right? We don't diagnose, and the patient's going to hear everything you're saying. Okay, just if you see the term aphasia on the exam, or aphasic on the exam, that is just the medical term for saying they cannot speak well, okay? They can't communicate, they can't talk and stuff like that, okay? But again, remember, stroke patient hearing is usually no problem whatsoever. There is one type of stroke that they used to call a mini stroke, or they call it a TIA, transient ischemic attack. It is basically somebody who had a stroke, but they were very, very, very lucky, and the symptoms resolved within 24 hours. So it's usually an embolic stroke. Obviously, it's not a hemorrhagic stroke because you're not going to be able to undo an aneurysm that burst. It's usually somebody who had a blood clot and the blood clot cleared, okay, within 24 hours. So they are extremely lucky. They're at like a 90% chance for having a massive stroke within the next year. So they're treated very aggressively with medications to reduce their risk of throwing clots. But it's all the signs and symptoms of a stroke, and they get better in your presence, okay? I had it only once. I had a guy that was clearly having a stroke, had a one-sided deficit, couldn't talk, and we were going to the hospital, and all of a sudden he started talking to me. And I was like, whoa, you know, and he's basically said, he goes, "I guess I got better." He goes, "Because my arm's working, I can talk and everything like that." So it's really just being extremely, extremely lucky that the clot actually broke loose, and, you know, the brain is now being perfused again. So, but that's what a TIA is, or transient ischemic attack. Now, on the stroke patient, what they're going to ask you on the test is, what kind of assessment do you do? So the assessment we do in the field is called the Cincinnati Pre-Hospital Stroke Scale, only because it was invented in a hospital in Cincinnati. Okay, so it's 3 steps. We ask the patient to smile. Okay, so grimace is the facial expression. We ask the patient to smile, and we see if there's one side that kind of drops down while they're smiling. Okay, we ask the patient to hold their hands out with their palms up, because you have to use a lot more muscles when your palms are up for 10 seconds, and see if one arm starts to drift down, or if they can't even do that, right? They can't even bring one arm up. Okay, and then we assess their speech and see if they have slurred speech or they don't have clear speech. So again, you look for facial droop. Okay. If they already have facial droop, you don't need to have them to smile, but it's, in other words, a patient that's looking at you and you don't see any facial droop, you ask them to smile and see if you see any facial droop. Okay. Then you have them put their arms straight out, close their, first of all, I should have said that. You have to have them close their eyes. The reason you want them to close their eyes is they say that a patient can force their arms up if their eyes are open and they see that their arm is starting to drift down. So you have them close their eyes, put their arms out, palms up for 10 seconds, and see if that one of the arms starts to drift downward. Okay. So, if one arm starts to, and it is true they usually turn their wrist back normally, right? So as their arm starts to come down, they do usually turn their wrist downward because it's easier for you. It's not normal for you to have your palms up and stuff like that. And then you ask them if they could speak. Now, normally we'll already have assessed speech by the time we got there because we already tried to speak to them. And if they speak to us clearly, then we can skip this. Or if they already had their slurred speech when we tried to talk to them, we could skip this part. So usually speech is not a problem. Okay. Now, the other important things are to figure out what's called the last known well. So the last known well is the last time the patient was seen 100%. So let's give a scenario. So I don't know, the patient was in the kitchen, alone, and the wife walks in and finds him, looks like he has a stroke. So you would have to say to her, okay, when was the last time you saw him 100%? And that would be the last known well. If somebody goes to sleep and wakes up with the symptoms, the last known well was the last time he was seen okay prior to going to sleep. The reason we need to know this is that some of the different therapies they could do for the patients depends on how long they've been having the signs and symptoms of the stroke. So sometimes like a patient who wakes up with, a stroke, they may be outside of the window of being able to treat if the last time they were seen was like 12 hours ago or something like that. We want to get a blood glucose level on them, right? Use the glucometer just to make sure it's not hypoglycemia appearing like a stroke, okay? We want to find out if there was any history of trauma in the last 12 months, because remember, somebody could have that subdural hematoma that Dov had talked to you about that's very slow to develop because it's venous, and that could take months to develop sometimes. Again, blood thinner use because they're more likely to have the hemorrhagic stroke. And then if they pass the first 3 tests of the Cincinnati, which is again the facial droop, the speech, and the arm drift, the other thing you could do is just have them stand up and maybe take a step or two and assess their balance. You need to be alongside them in case they fall, but sometimes people who are having mild strokes can pass the first 3 tests, but fail the walking, fail the balance part of it. So it's just, again, you never do that unless there's people that could stabilize the patient and stuff like that. Okay, now what else do we do for them? Okay, so again, we want to talk to them. We want to calm them down. You don't want their blood pressure to get high. Explain to them there's definitely stuff that could be done for them, okay? If they're having problems clearing their secretions or anything like that, you may need to suction, but that's very, very rare. That doesn't usually happen. Okay, again, oxygen, not usually necessary, but you can be guided by pulse oximetry, but they usually don't need any oxygen or anything like that. Transporting semi-Fowlers means that you don't want to lay them flat. You want to have them slightly inclined up onto the stretcher, right? Not lying flat, because that will decrease the pressure to their head. So that is important, okay? If they are unconscious, okay, then they need to go flat, okay? Just, because they could vomit, try to put them on their side in the recovery position and stuff like that. Again, put them on some oxygen if they're unresponsive and transport. Now, I have question mark, because where do these patients need to go to? So in Rockland County, it doesn't matter because both Good Sam and Nyack are stroke centers. But if you were in a place like even New York City, like not every hospital, because there's so many hospitals in New York City, not every hospital is what's called a designated stroke center. So all it means with a designated stroke center is they have a functioning CAT scan machine and they have a team in place to manage patients who come in with strokes. Any hospital could have this designation if they have the right mechanism in place. But in Rockland County, it doesn't matter. Between our 2 hospitals, they both have stroke teams. They're both capable of taking care of stroke patients and stuff like that. So that's all I was saying there. Okay, again, so if you're in a place that, well, let's put it this way. Before Good Sam and Nyack both had multiple CAT scan machines. If you go back 10 years ago, they each had 1 CAT scan machine. So if a CAT scan machine went down in a hospital, you could not take stroke patients to them, trauma patients to them, head trauma patients to them, because all those patients need CAT scans to figure out what's going on with them. So if, let's say, I don't know, Good Sam's CAT scan machine went down, they used to actually put out over the county radio, every hour, Good Sam's CAT scan machine is down. And this way we knew not to go down, take any of those patients to the hospital. Okay, but again, since the first test that every stroke patient has to have is a non-contrast head CT, the hospital has to have one working. Okay, we're almost done. So we're done with the stroke patient now. Okay, now dizziness or syncope. So syncope, dizziness, you know what that is, but syncope is fainting, right? Is the medical term for simple fainting. Realize that it is not common, right, for people to faint. So there could be a medical reason why somebody is fainting that has to be evaluated in the hospital to figure out what it is. So that just because somebody faints and they are fine now doesn't mean that they can stay home, because they could have had an abnormal heart rhythm that caused them to faint, and now that abnormal heart rhythm is not there anymore and they woke up again. But the next time they may not be so lucky. So when somebody faints and there's no clear reason, like if somebody said every time I see blood I faint, and they saw blood and they fainted, I'm not saying that patient needs to go to the hospital unless they hurt themselves when they fainted. But if somebody gives you no reason why they fainted and they have no history of fainting, then that patient does need to go to the hospital and see what's going on. Now, dizziness is the term basically where either you're spinning or the room around you is spinning, okay? That could be a sign of neurological problems. That could be a sign of a problem called vertigo, which is really a problem with your ears. Our balance, our sense of balance is based on our ears. We actually have levels, fluid levels, just like when you have put a level on a piece of wood in our ears that, tell you your balance and stuff like that. So when people have ear infections or people have problems with that balance, they can feel like the room is spinning or they're spinning and stuff like that. Syncope, again, is the medical term for fainting, okay? And a syncopal episode means that somebody just fainted. We've talked about this before with the vasovagal type of patients where, they strain on the toilet or they get bad news and they have an activation of their vagus nerve and they slow down their heart rate and vasodilate and faint. Again, in that case, you can kind of understand why it happens. So they need to be examined for any trauma when they fainted. But if they start to recover and their blood pressure starts to come back, it's probably not a real serious problem. That's the vasovagal type of syncope and stuff like that. Obviously, if somebody's heart rate goes very slow, they can faint because they're not putting out enough blood. And the same if the heart rate goes very fast, the time between each contraction, right, is so minimal that the ventricles don't have time to fill up with blood. So again, their blood pressure would go very low. So those are all just common reasons why people could faint. But in general, people who are fainting should be evaluated at the hospital. Again, it could be from vomiting or diarrhea where their blood pressure is low. It could be from bleeding where their blood pressure is low and they're fainting, okay? Problems with your ears, ear infections, right? Middle ear infections, swimmer's ear and stuff like that can make people very, very very sick because it throws off their sense of balance. Drugs, alcohol can make people sick or dizzy and stuff like that. And then there's people who faint and they can never figure out why it is, or people who are dizzy and never figure out, why it is. But again, that's not our job to say that they could stay in the house and stuff like that. So when we're assessing them, has this ever happened before? Okay. Can you describe to me when you say you feel dizzy, what exactly does it mean? Are you, I don't say to them, are you spinning or is the room spinning? I say, can you describe to me what your dizziness feels like? And then let them, describe what's happening. Okay. Do you have any warning before it starts? Okay. When did it start this time? How long did it last? Has it ever happened before? What position were you in? A lot of times when people suddenly get up and feel dizzy, we know that's probably normal, just because when they were laying flat, their heart didn't have to pump real hard to perfuse their brain, but now all of a sudden they suddenly stand up, their heart has to pump much harder, and sometimes it doesn't do it quick enough. Are there any medications that can lead to this, or are there any medications for this type of problem? Any other signs and symptoms, right? Did they get nauseous right before they felt they were going to pass out or anything like that? Was there some kind of psychological reason, an unpleasant sight, vomiting or sound or blood or something like that? Okay, did you hurt yourself when you fell? Okay, was there any history of any kind of seizure activity? Because then it's probably not just fainting, it's probably actually they had a seizure and they fainted when they were because of the seizure and stuff like that. Again, oxygen is fine based on the patient's pulse oximetry levels. If you have access to ALS, that's fine, but I don't know that every one of these patients actually, if they're stable, needs a paramedic. Okay, any loose clothing that's causing problems with blood flow should be loosened. Even a belt sometimes can interfere if somebody's very, very fat. If their blood pressure is low or they feel dizzy, they usually feel best if they're lying flat. Okay, always check if there's any injuries from when they fainted and stuff like that. And then just a couple questions and then we'll call it a night. So is seizures and syncope a symptom of a larger problem? Could be, right? Or could not be. In other words, if a patient has a history of epilepsy and tells you they stopped taking their medicines and has a seizure, then you know what the answer to your question is. You know they had a seizure because they're non-compliant with their medications. Then it just comes down, did they hurt themselves when they had the seizure? The same thing if somebody fainted because they saw blood and every time they see blood, they fainted, there's probably no big medical problem, right? This is just a typical vasovagal. But if, again, they need to be examined to see if they hurt themselves. But if somebody had no history of seizures and suddenly had a seizure, we're afraid that they may have something inside their head, right? A tumor or a bleed or something like that. Okay, so just to review real quick. So again, diabetic emergencies for the most part are caused by the fact that somebody is a diabetic and they're not managing their diabetes well, right? So they're either not managing their amount of insulin or not managing their amount of foods. Okay, we said there's two types of diabetics, the type 1, which is that they are not born with the cells that make the insulin, okay, and they need to take insulin for the rest of their lives, and type 2s, where initially everything was fine as far as their ability to produce insulin, but because they were grossly overweight for a long period of time, their cells got resistant to their own insulin, and they're not allowing the insulin to bring the sugar into the cells, okay? And then we said there's two types of diabetic emergencies. There's the low blood sugar emergency that we call hypoglycemia, which rapidly occurs, and the skin typically gets cool, pale, and diaphoretic because of the adrenaline release into the bloodstream. Those patients need sugar, but again, if they're so unconscious that they can't swallow without any risk, we can't give them sugar. We just would transport them or have ALS meet us at the scene to start an IV. And then there's the high blood sugar emergency called hyperglycemia, or more correctly, diabetic ketoacidosis. Okay, that's very slow to develop over days and even a week. Okay, those patients, the typical cause is that they get an infection that throws their body out of whack and they can't control their blood sugar, and the blood sugar quickly starts to rise. Okay, in the low blood sugar emergency, they drop their sugar for one or two reasons, which is they either take too much insulin or don't bring in enough food. But in the high blood sugar emergency, again, it's usually the infection throwing them out of whack. They're not taking their insulin, and their blood sugar starts to climb to dangerous high levels. There, they typically have that abnormal breathing that we call Kussmaul respirations, where they breathe deep and rapid, and they have that acetone-like odor on their breath, and they may have the excessive eating, drinking, and urinating. Okay. Seizures, we talked about that the worst type of seizure would be the tonic-clonic or grand mal seizure. And then out of those, the worst kinds of that is the status epilepticus, where they have repeated seizures without regaining consciousness. There's many different reasons why people can have seizures, but the most common reason is the disease of epilepsy, and that the patient is not taking their medications to control their seizures like they're supposed to, or that they are taking their medications to control their seizures and they're drinking alcohol. Okay, that's the two number one reasons. And then anything else can cause a seizure. We said head trauma, temperature, fever, anything like that. Okay. A stroke, we said, is a interruption of blood flow, okay, to the brain, into the arteries of the brain. It can be caused by a blockage or a rupture. The blockage one is called a dry stroke or an embolic stroke or a ischemic stroke. Okay, and the wet one is called a hemorrhagic stroke, where the blood vessel has an aneurysm and ruptures and stuff like that. We said the signs and symptoms of stroke typically are one-sided weakness or paralysis of the extremity with slurred speech, difficulty in walking, difficulty in swallowing, and stuff like that. And that we would do our stroke assessment, which is called your Cincinnati Pre-Hospital Stroke Scale, and that looks for three things. We assess the patient's speech, see if there's any slurred speech. We have the patient smile and see if there's any facial droop. And we have the patients hold their arms out with their palms up for 10 seconds with their eyes closed and see if there's any arm drift. Okay. And for stroke patients, basically, again, oxygen guided by pulse oximetry, protecting their airway, try to transport them sitting up a little bit so there's less pressure going to their brain. What else do we say? With syncope, again, many different causes. We just talked about that. But again, the big thing would be to see if there's a history of fainting and is there any trauma, that they hurt themselves on the way down and stuff like that. Okay, if the cause of the patient's altered mental status is hypoxia, obviously the treatment would be oxygen. If the problem is a low blood sugar emergency, then the treatment would be to give them sugar as long as they could swallow it without any danger of aspirating it. And the other important thing with the stroke patient is to try to figure out the last time the patient was seen 100%, so that you can get an idea of when the stroke actually occurred, because that will play a role in the neurologist's treatment of the patient and stuff like that. Signs and symptoms of diabetic emergency depends on whether it's low or high, but if it's low, we said rapid onset with cool, pale skin, okay, and obviously a change in their mental status up to including unconsciousness. If it's the high blood sugar emergency, we said slow to develop, days up to a week. Usually infection is the precipitating cause. Their skin is usually warm and moist, not cold and moist. And they have the Kussmaul deep rapid respirations, the acetone-like odor on their breath, and the extra drinking, eating, and urinating as the kind of the history. Treatments for the diabetic would be, if it's low blood sugar emergency, they could swallow without any danger, to give them oral sugar to swallow. If you can't do that because they're too deeply unconscious, it would be transporting them to the hospital in the recovery position to get sugar in the hospital, or have ALS intercept you. The high blood sugar emergency, again, is not really much we could do for them, other than protect their airway and transport them to the hospital, because they need insulin and we don't carry insulin. We talked about the steps for the stroke patient as far as the assessment, which is the Cincinnati. Again, we just talked about that. Conscious to unconscious stroke patient. So a conscious stroke patient, again, would be some psychological first aid, explaining to them, there's definitely stuff that could be done for them, keep them sitting up so there's less pressure going to their brain. Unconscious stroke patients, again, you have to protect their airways, so they're probably going to go into recovery position. Oxygen, again, most of the times is not needed in stroke patients, but you can be guided by their pulse oximetry. If it's below 94%, probably put them on a couple liters nasal. If it's real low, then maybe a non-rebreather. Okay, patient who fainted or is dizzy, probably keep them flat. Maybe their legs elevated a little bit to get a little more blood back to them, and put them on some oxygen and transport them to the hospital for evaluation. And then we have a 62-year-old male is witnessed to have a tonic-clonic seizure. So that's that grand mal seizure. You find him actively seizing. His skin is pale, moist, and slightly cyanotic. Immediate treatment. So again, protect him from hurting himself, nothing in his mouth, okay? And you could try to put some supplemental oxygen on him, see if that improves his cyanosis. You could try bagging him, but both of those are very hard to do when somebody's bouncing along, but you do the best that you can, okay? And then once the seizure stops, then you could provide more, definitive care to him. Okay, so any questions? I mean, we did a hell of a lot of stuff tonight. I apologize to try to squeeze this all in, but Saturday night, we'll definitely go over some of this. If anybody has questions, we'll go over, test questions and stuff like that. I'll set it up Saturday night probably for about 8:30 and stuff like that. I see a lot of people had a lot of questions, but it's a little late already. So just hold on to your questions for Saturday night, and we'll go over them then. Okay. So everybody have a good night, and I'll see you guys after Shabbos. Okay.
Thank you.
Take care.
Good night.